Mike. You have to just.
Can we do it?
Yeah.
So if you have a big problem.
Good morning. A very good morning to all of you. I hope many of you had the opportunity to attend and benefit from the insightful sessions that took place yesterday. My name is Dr. Mohita Srivastav, and I have the honor of standing before you today as the chairperson of this distinguished joint event. The 4th International Dental Advanced Dentistry and Oral Health UCG Congress and the 16th International Healthcare Hospital Management, Nursing and Patient Safety Conference. It is truly a privilege to address such an exceptional gathering of professionals from across the globe. This Congress stands as a shining example of how collaboration and knowledge sharing can drive innovation and progress in our fields. It is inspiring to see experts from dentistry, oral health, healthcare management, nursing, and patient safety unite under one platform to exchange ideas, innovations, and best practices. So, I look forward to an inspiring and productive day together. I would like to mention about a few lines about UCG conferences. Utilitarian Conferences Gathering, UCG is proud to lead in organizing professional settings, conferences, workshops, and symposium, is specializing in medical clinical healthcare, life sciences, and pharmaceutical fields. UCG bridges academia and industry with innovation and excellence. With 24 by 7 support, global reach, and a dedicated organizing team, UCG ensures every event is impactful and tailored to the needs of its participants. On behalf of UCG, I extend heartfelt gratitude to the organizing committee, our distinguished speakers, and every participant who made this gathering possible. Together, we are shaping the future of healthcare. Thank you, and I look forward to an engaging and fruitful day too with all of you. So let us begin. So I would like to tell to all the presenters here that you have 20 minutes for the talk. And I would really appreciate all of you to end your presentation on time, keeping in mind that we have to end the conference and we have to progress for rest of the speakers to speak on the stage on time. And I will be giving you cue 5 minutes before your talk ends. And so please keep an eye on me also, not only on your slides and, just you're engrossed in your presentation. And after, I'll be having 2 or 3 minutes for your question answer session after your presentation. So, our first speaker is, I would like to welcome our very first speaker for the session today. Our first speaker is Dr. Safa Baz from Egypt, Assistant Professor of Oral Pathology at the British University in Egypt. Her talk is titled Synergistic Anti-Cancer Effects of Cisplatin and Pomegranate Extract in Head and Neck Squamous Cell Carcinoma. Please join me in welcoming Dr. Safa Baz. Thank her after the speech. Okay. Good morning. I am just going to put your presentation. Okay. Thank you. The stage is all yours. Thank you.
Good morning, distinguished colleagues. It's a great honor to be here with you today at the 4th International Dental Conference UCG in Dubai. My name is Safa Baz, Assistant Professor of Oral Pathology at the British University in Egypt. I'm delighted to share my work with you, my recent research titled Synergistic Anti-Cancer Effects of Cisplatin and Pomegranate Extract in Head and Neck Squamous Cell Carcinoma. According to the program of the conference, I'm the first speaker. I hope the secretary, someone will go before me to start the presentation to break the ice, but I will do it myself. Let's start with a brief background. Head and neck squamous cell carcinoma is a heterogeneous group of epithelial malignancies in oral cavity, pharynx, hypopharynx, larynx, nasal cavity, and salivary glands. The global rankings of head and neck squamous cell carcinoma, it represents one of the top 7 cancers of all cancers worldwide. The incidence of cases each year is 890,000 new cases, while the mortality is 450,000 deaths every year. The 5-year survival rate, unfortunately, is less than 50%, despite the advances in treatment. The clinical burden is in 2 points: late diagnosis of head and neck squamous cell carcinoma because of the hidden sites most of the time, besides the functional and hepatic impairments, speech, swallowing, and breathing. Current treatments, such as, or basically the surgery, chemotherapy, and radiotherapy, remain has significant side effects and limitations to the patients. Cisplatin is the most commonly conventionally used chemotherapeutic agent in treatment of head and neck cancer. It targets the DNA damage, so it's highly effective in controlling tumor cells. Meanwhile, it has serious side effects like toxicity to the normal cells also, besides the acquired drug resistance with the acquired doses. This necessitates exploration of alternative strategies and combination therapies to reduce toxicity while preserving efficacy. This brings us to explore natural compounds, okay, to overcome the toxicities from the conventional chemotherapeutics. The pomegranate extract is Latin name Pionica granatum L, is a bioactive natural compound rich in phytochemicals, flavonoids, tannins, phenolic acids, and nutrients also. It's derived from peel, juice, and seeds of Pionica granatum family, okay? In our study, we used extract from all these parts, okay? The biological activities for centuries, pomegranate has been used in traditional medicine as an antioxidant and anti-inflammatory agent, okay? Modern research have revealed its anti-cancer potential also in multiple cancers, such as breast, lung, and colon cancers. Study objectives. From this standpoint, this study was designed with 2 key objectives. The first, to evaluate whether pomegranate extract alone or in combination with cisplatin could induce cytotoxic, anti-proliferative, and apoptotic effects on HEP2 cells, which is the model used in head and neck squamous cell carcinoma in this study. And the second, to investigate whether the combination of cisplatin and pomegranate could demonstrate a synergistic effect and whether it has superior effect than using the conventional cisplatin in head and neck squamous cell carcinoma. Material and methods. To conduct this study, we used cell line HEP2 cells, which is human epithelial carcinoma cells derived from head and neck squamous cell carcinoma, and then divided the groups of the study to 4 study groups. The first, untreated control, the second, third, fourth are treated groups. Cisplatin group, pomegranate extract alone, and combination of both of them to see the effect. The assays performed MTT assay to measure self-viability and to determine IC50 values, histological examination, using conventional H&E staining, hematoxylin and eosine, to visualize the morphological changes. Immunocytochemistry, using Ki-67, the common indicator of cellular proliferation, and BCL2, the anti-apoptotic marker, to assess protein expression levels of both of them. Then last step in the assays were PCR, real-time quantitative PCR, using the same genes of Ki-67 and BCL2 to assess expression levels of these genes. Statistical analysis. Data were analyzed using one-way ANOVA followed by Banff-Rawney post-hoc testing with significance level set at p-value less than 0.05. Let's move to the most exciting part of this presentation. Cytotoxicity and IC50 results revealed that the HIF2 viability was lower in the CES group and the combined group compared to the control. Pomegranate extract surprisingly showed the reduction in cell viability of cancer cells, which is promising, but remained higher than that of cisplatin. Okay. The IC50 values revealed that the lowest levels were, it's not like this, higher level, the lowest level were in the conventional chemotherapy cisplatin and the combined. And these doses were used to the consequent steps. To validate the previous step, we examined the histological sections. And in the control group, the cells were confluent viral cells, as you can see. Okay. Then, in the other groups, the apoptotic features start to be seen. You can see the beveling, the beveling of the nucleus, denoting chromatin condensation and starting to apoptosis. Okay, and apoptotic cells like this, shrinking hypnotic nuclei, apoptotic bodies, fragmented nucleus with membrane-bound vesicles, you can see it. All the apoptotic signs were seen, which reflect the occurrence of apoptosis of the cells when treated with the different treatments. But to validate these results, we go through the immunocytochemical analysis. The first to express the proliferation of Ki-67. The results reveal nuclear expression of all groups by Ki-67. The highest were in the control. Meanwhile, the most reduction were in the combination group. Okay. Regarding the BCL2, it's an anti-apoptotic marker. Anti-apoptotic action. The normal, if it's the anti-apoptosis in normal increase in cancer to be effective, it should be lowered. So surprisingly, it emphasized the previous result, the anti-cancer activity, and the most decreased in the combination group. All these results emphasizes the synergistic activity of both using pomegranate extract with cisplatin than using either treatment alone. As we can show, this is the statistical result with significant differences between the groups, and we're emphasizing the same idea, the lowest in cis and pomegranate combination. The real-time PCR results further validated the results with the same lowest in the combination group, as we can see. So all the results across all the assays, cell viability, cellular morphology using H&E, immunocytochemistry using Ki-67 and BCL2, PCR to validate the gene expression, these findings remain consistent, cisplatin and pomegranate extract work better together than either monotherapy. Conclusions and recommendations. Pomegranate extract therapy demonstrated anti-cancer activity, cytotoxic, anti-proliferative, and pro-apoptotic effects on HEP2 cells. However, its efficacy remained lower than the cisplatin, okay? Meanwhile, the combined therapy, cisplatin plus the pomegranate extract, indicated stronger cytotoxic activity and anti-proliferative and pro-apoptotic activities against cancer cells compared to cisplatin alone, which confirms synergy. This synergy may lower the doses, and this is the most important part of the idea of the research, that we have to lower the doses of conventional chemotherapy, not to avoid using the chemotherapy, but just to lower the dose with the natural compound, adding natural compound to take the cytotoxic activity of the natural compound, meanwhile minimizing the toxic activity of the chemotherapeutic. The recommendations: further preclinical studies should be conducted to investigate the underlying mechanisms behind the observed synergy. Dose optimization studies to determine the most effective and least toxic ratios of the combined cisplatin and pomegranate, the exact ratios. Actually, we started in this step, the next experiment. Long-term safety and toxicity profiles of combination of therapy should be evaluated. Potential clinical application, clinical trials to validate the combination of safety and efficacy of using of the combined therapy. I want to thank my colleagues, Dr. Judy Kamala, Dr. May Hafiz, Dr. Heba Mahmoud, who shared me this work from the Faculty of Dentistry, the British University in Egypt, and the Gulf Medical University here in UAE. Thank you. Any questions?
Thank you, because we're on time. The floor is open for the questions now. Can you just elaborate upon what the kind of pomegranate extract you told, right? The pomegranate extract. So how is it extracted? What is it? Is it sterilized or for like obviously for medical use, right? What is the thing about the processing of water?
Yes, it's bought from a common company in Egypt. Then in Faculty of Pharmacy in our university, some experiments were performed to ensure the characterization of the extract and to exclude the inactive ingredients in the extract.
Something very simple. So if we include pomegranate extract or juice on a daily basis, is it very good that anti-cancer?
You mean in chemoprevention, not in cancer?
Is it good for normal individuals to prevent?
Yes, sure, but this is the chemoprevention idea.
Yeah.
To prevent cancer, not to treat, not to wait until cancer occurs and then treat it. Because the pomegranate is very rich in phytochemicals and in antioxidant ingredients, which scavenge cancer cells.
Scavengers.
Yes, scavenge at the beginning. When it starts the cells to get away from the normal cycle, it detects the pomegranate could detect the cancer cells from the beginning and scavenge it. It has also radioactive species, free radicals, oxygen and nitrogen radicals.
So routinely taking is very good.
Yes, of course.
Thank you. Thanks so much.
Most welcome. Any questions? Thank you.
Thank you.
No?
Yeah. Thank you.
شكرا.
Thank you. So it was a very nice talk, Dr. Safa. Our next speaker is Dr. Khalid Beramo from Azerbaijan, a specialist in dentistry. He will speak on adhesive protocols and classification of bonding systems in restorative dentistry. Let us warmly welcome Dr. Khalid. Dr. Khalid, please.
So first, we like lasers to show user presentation. If you have anything like lasers, I think that's music. I think this one will. If we can ask outside, you can use it. It will look good. Yeah. Yeah, it's working. Okay. What point is traffic? Not so problem from seconders, but microphone feature.
Hello again, good morning everyone. I'm so honored to be part of this international conference. My name is Khalid Bayramov. I am from Azerbaijan. I'm graduated in Istanbul University Chakra Faculty of Dentistry, which is one of the main faculty in our region and in Turkey. Today we have got a very important subject on adhesive dentistry and restorative dentistry. We start with adhesion and classification of dental bones in dentistry. So we have got so many mixed terminology in adhesive dentistry, and today I'm trying to explain as much as possible. So we have got different etching type like self etching, selective etching, total etching, immediate and sealing, hybrid layer, and several generations, multi-mode, sealant, wet bonding, smear layer. They are so like a mixed terminology, but we will open this. So consequence of improper adhesive protocols. So if you don't use every step clearly and correctly, which problems we will get? So postoperative sensitivity, postoperative pain, partial fracture of the restoration, debonding of the restoration, and the marginal discoloration. So we could have many problems. That's why we have to use carefully on every step. Adhesion. The adhesion originates from the Latin word adherere, meaning to stick or cling. In adhesive dentistry, the bonding agent is the adhesive and the tooth strand is the adherent. And we have got three main steps on adhesive stem preparation. The etching process, applications of the primer, and the adhesive applications. Every step is so important for us. And we will see that the main goal of the manufacturers is make these three different steps like a one. So in one bottle, they try to make a one so strong bottle which handle all the steps. So etching types. We have got three main etching types. They are total etching, selective etching, and no etching system. First of all, total etching system, which we etch in this system type, both dentin and EMA. So this is like a gold standard, and we use this total etching type on fourth and fifth generations. This is gold standard for the adhesion, but it has got a very important weakness, which is it causes postoperative sensitivity. That's why in this stage we don't use this etching type so much. So second one is selective etching, which we use on 6, 7, and universal bonding types. In selective etching, we just etch the enamel, not the dentin. So it's good. We will not have a postoperative sensitivity after the selective etching. Its adhesion is not so much strong as a total etching, but strong enough. So it's good for the postoperative sensitivity, and it is normal for the adhesion. So in these days, generally we use these selective etching systems. And third one, no etching system. Also on all the self-etch systems, we use this no etching. So so with no etching system, of course, we will not have any postoperative sensitivity, but adhesion also will be low. So and here we have got some pictures. I will explain it on the next station. So etching on enamel. Etching on enamel and dentin are the different. On enamel, it is more easy than the dentin. We use generally, as you know, 37% of phosphoric acid, 30 seconds, and it creates between 5 and 15 micrometer microporities, and ancient mechanical retention, facilitates bonding agent penetration, and it's easy to etching on the enamel. We have to thoroughly rinse the acid after etching, of course, and we have to protect its surface from the saliva or moisture. If salivary will affect to the enamel, we have to re-etch it as a 15 seconds after that. So it's not so challenging on the enamel etching. But etching on the dentin is more challenging. Why? Because dentin has a higher organic content, it has dentinal fluid, and it has got smear there. So we have to etch it so sensitively. On the picture, as you know, when we etch on the dentin, it dissolves the peritubular dentin, and we see collagen fibrils appear. So when peritubular dentin dissolves, we see collagen fibrils and the dentin tubules which have dentinal fluid. So we have to be very careful on after rinsing of the etching, because if we over dry it, collagen fibrils will be collapsed and it will be bad for our adhesion. And if we will not dry it enough, it will be again bad for the solvent station. So it will be better when we use, instead of just drying with air, it will be better with cotton pellets, sterile cotton pellets, and it will be enough drying. So we have to use sterile cotton pellets, of course. And what is the effect of 30-second phosphoric acid and etching on enamel? Phosphoric acid etching ensures resin bonding by creating micro-retentive space in enamel. So our adhesion's main goal is creating this micro-retentive space. If you don't have enough microporities, it will not be enough adhesion. In fourth and fifth generation adhesive, its low pH also provide us antibacterial effects. So it means in total etching we have also got antibacterial effects, but in self etching it is no, if we don't have. And in selective etching we have just low antibacterial effect. So that's why in selective etching and self etching we can use additional chlorhexidine to make antibacterial effects. So second one, what are the consequences of the inadequate rinsing right after acid etching? Of course, inadequate rinsing can lead post-op sensitivity and reduced adhesion. And in which adhesive system is enamel etching is recommended? Actually, in total etching systems, acid etching is essential. However, etching is generally recommended across all the adhesive systems because it ensures bond strength. So without adhesion, without etching on enamel, we will have so low adhesion. And etching and adhesion in dentin. What are the effects of etching dentin for more or less than 15 seconds? In space etching results in poor adhesion. We couldn't remove the smear layer correctly, and we wouldn't have enough microporities. And over etching, so more than 15 seconds, cause deep demineralizations that adhesive can't penetrate, leading to again non-leakage and post-op sensitivity. So, and what are the potential risks associated with rinsing of the acid etchant? Over drying, as I said, collapse collagen fibers, while excess moisture dilutes the primer, both reduce bond strength. And third one, which adhesive system class are more suitable for bonding to dentin? Self-etch and universal adhesives are preferred for dentin because we don't use total etching and we will not have phosphorative sensitivity. But as we said, self-etch are not so, they are big on the adhesion. So this selective etching and universal bond are the best for today's choice. So second one, first we talk about etching. So we have got, after etching, we have got some microporities on dentin and enamel. Second one, we use primer. Primer increases surface energy after etching. Made from hydrophilic monomers, dissolved in solvent acetone, ethanol, tritol, butanol, and etc. Penetrate collagen fibers in a wet environment which we call wet bonding. For the adhesion, for the bonding, we have a wet environment. If we don't have wet environment, if it will be over dry, it will be problem for the bonding again. And we apply the primer just 20 seconds and dry until moment stops. Here, we can see the collagen fibers, the hybrid layer, and primer. So if we overdrive this collagen fibers so much, we can see smear after the smear there is a dentin tubes. If we overdry it, collagen fibers will collapse like that. We can see, and we don't have enough microporities for the adhesion. So here we have got a so small hybrid layer and so weak adhesion. But here we use sterile collagen penne, so we not overdry it, and we have got deep microporities, and hybrid layer is also strong at here. So main goal is not making overdrive. And third step, adhesive. We use etching, we use primer, and then it comes adhesive for making a hybrid layer. Adhesive applied after primer to stabilize a hybrid layer. It completes with HMA, take the and small part HMA. It penetrates dentin tubes, form resin tanks, polymerized after bath. This is the main thing, forms resin tanks and hybrid layer. So here we have got a smear layer. Here we have got dentin tubes. After we use total etching system, we can see here collagen fibers. And when we use primer and adhesive, it's like we have got a hybrid layer. So it's so important. When we use total etching hybrid layer like that, it's so much big here, and we have got a dentin fluid. So that's why it could be post-operative sensitivity also. So we have to be very careful. On the right picture, we again see dentin adhesive layer and the composite. So the main thing is if our adhesive layer or hybrid layer will not be strong enough, it will be problem with our composite, with our filling. And again, hybrid layer, all the steps performed aim to create a properly formed hybrid layer. If our hybrid layer is not we perform it correctly, it will be a problem on our filling, on post-operative sensitivity. For strong adhesion, the hybrid layer must be robust and well formed. A strong hybrid layer directly correlates with strong adhesive bonding. And the adhesive resins form resin tags that infiltrate and stabilize the resulting hybrid layer. Resin tags on this picture again we see same things, the total etching, collagen fiber, and And the bonding mechanism to enamel and dentin can be likened to an adsorption process. So we remove some mineral, calcium phosphate, are replaced by resin monomers introduced through bonding. Small historical classification of bonding. First, it introduced by Blocker, and this Blocker only etched enamel with 85% phosphoric acid. Of course, it was so big, just between 2 and 3 megapascal bonding force. And then on second generation, they introduced only bonding to smear layers, then a bit more strong, 10 megapascal. And by Fusayama, it was first time on third generation, first time etched to dentin, first time used phosphate-based schema, first time primary introduced, first time hybrid layer concept introduced by Fusayama. And then we have got fourth, fifth, sixth, and seventh, and universal generation. This is our modern classifications. So at the left side, we have got fifth generations, and sixth generations, which we use total etching system. And then on the right, we see seventh and one step, sixth and one step universal or self-etch generations. We will talk about, and some examples to these bonds. Optibond care, which we use as a fourth generations and fifth generations, the other generation basically. And on the right side, we see clear field bond, which is one example, one important example for the sixth generations, which we'll talk about. So step by step generations. First fourth generation, this is we call as a gold standard. Why? Because we use total etching system and it is so strong for adhesion. We use acid primer and adhesives. Sort of total etching system we use. We of course etch both of the dentin and emal completely etched. The smear layers entire block removed. With its strong adhesion, we call this as a gold standard. As a main example of fourth generation is Optibond by Cher. But it has got so important weakness. which it has a risk of postoperative sensitivity if not performed correctly. Why? Because we talked about we use total etching system on this system. 5 minutes. Okay. I will try to test. So we use total etching system and it has got postoperative sensitivity. It has got time-consuming applications because it has got 3 steps and it requires the technique sensitivity. It requires multiple clinical steps and relatively high cost. That's why this we call gold standard, but it is so risky to use. So as part of our work, we have used the fourth generation. And then we have got fifth generations. Now we have got just 2 steps. One step is just for etching, and the second step is both the primer and bonding. And it is also strong generation, but it has got also weakness. So lower bond strength, technique sensitivity procedure, because we use total etching again. And then we have got sixth generation. It's also 2-step generations, but it has got some strong point. We don't use additional etching, so that's why it will not be postoperative sensitivity. And it also the smell layer is not fully removed and utilizes a surface or selective etching technique. So that's why it doesn't have the postoperative sensitivity. So this is also we count as a gold standard. So both fourth and sixth generations. And then some examples for the sixth generations and seven generations. No, we have got just one bottle. So as you see, we start from 3 bottles, different steps, we're going to one bottle. So manufacturer's main goal is making it just on one bottle. So on 7 generations, they have got this, but this is not enough for us because we use just self etching system. We couldn't make a selective etching. That's why it will be postoperative sensitivity, but it will be effect to our bone strength. So bone strength on 7th generation is so big. So, but of course, it reduces technique sensitivity. It has got fewer technical steps and faster application. But in daily life, it has got so big adhesion. So that's why we don't recommend to use this generation also. And some examples for the same generations for the clarified G bond, bond form, beauty bond, and finally, we have got 8 generations, which is we call universal bond, multi-bond. For today's, this is the best option we have got because we can use it with all etching types like selective etching, total etch, and selective etching. It low technique sensitivity because it is just one bottle and we use just one on 20 seconds. It has got single step time efficient applications. It creates a thin intermediate layer ideal for indirect restorations and it have got some formulations contain sealant, which as you know, it enhances ceramic bonding. We need this sealant for our ceramic systems. It presents on 10-methyloxydacyl dihydrogen phosphate functional monomers, which enables chemical bonding with calcium hydroxide and it's forming a stable monolayer. So it promotes a stronger and longer lasting adhesive interface. So it's so strong for today's use, general motion, but it also have got some weakness, which are bonding layer thickness formed after application is relatively thin. It's like 10 micrometers. So it may lead to microleakage due to the internal fluid. That's why we have to use immediate intensity. When we use this 8th generation universal bond, we have to use immediate intensity so to prevent microleakage caused by the thin adhesive layer. 10 microns is so good for the indirect restorations, but not good for the normal filling. So we have to use after flow composite. Due to the mild acidity of the adhesive, we have to use selective etching of enamel is recommended to ensure adequate bonding strength. So in daily life, it will be better to use selective etching on these 8 generations. And it has some sealant content, but it's not so strong. So if you use indirect restoration, we have to use additional sealant. And some examples for these 8 generations. So we have put a limit time, but I tried to explain every step. Now we know universal adhesive, etching types, and immediate intensity, which is so important, and different generations types, sealants, hybrid layer formation, which is the main thing is here is hybrid layer formations of it's our goal on adhesive industry. Thank you so much.
Thank you, Dr. It was really wonderful.
Actually, it was a so long subject, but I tried to make it small time.
Thank you. Thank you
Evet.
so much.
No time for question, I think.
Yes.
The subject for 1 hour, but 20 minutes.
Nauseous. That person.
Thank you.
Thank you.
So, our next speaker is Mr. Abdullah Awad Al Rashidi. So, we are pleased to welcome Mr. Abdullah Awad Al Rashidi from King Abdullah bin Abdulaziz University Hospital, Saudi Arabia. His talk is titled Quality of Work Life and Related Factors Among Nurses in Emergency and Critical Care Departments in Saudi Arabia in 2023, a cross sectional study. Please welcome Mr. Abdullah.
Thank you, everyone. My name is Abdullah Rashidi. I'm head nurse for day surgery in King Abdullah bin Abdulaziz University Hospital. And I'm glad to share our research today with you guys. So our study was about the quality of work life in emergency setting, like emergency department and ICU for the nursing. So before we start with the outlining for the study, I put some questions just to keep you connection with the importance of this study. So first, if the nurses are exhausted and unsupported, who will provide the care for our patient? So especially in this career, we're dealing with patients, so the outcome of the how they feeling, it will show in the patient. So we keep also heard that the nurses is the backbone for the healthcare system. If they supported or not supported, in this study, we will explore the relationship and we'll see if they really supported or not. So the background, high nurse turnover rate globally, and also burnout and job dissatisfaction in the critical area. Also limited research to support the quality of work, nursing work life. Also, nurse work life impact job satisfaction and retention and job patient care outcome. Poor quality of nursing work life linked to the burnout and stress and turnover. Emergency and ICU based previous research showing that facing a unique stress. Also, quality of nursing work life linked to the patient safety and healthcare system stability. High turnover is costly and unsafe for the patient. Also, enhancing the quality of nursing work life is a globally nursing priority. So here is systematic review showing was published in 2024, showing the global nurse turnover rate between 8 and 36, and the average is 16, which is really high, significantly high comparing with other careers. Here also a report was published by NSI in US, showing the average of cost for the turnover in nursing, which almost 61,000 per each single turnover. And here is a meta-analyzing and systematic review in 85 study, including more than 288 nurses, showing that low job satisfaction in nursing associated with low patient safety. Study objective, the primary objective was to exclude or to examine the relationship between the nursing workload and workplace and demonstrate and overall quality of nursing among emergency and critical care nurses. And the secondary also to assist individual quality nursing work life, subscale demand, and define predictive of high work satisfaction, and provide insight for policy development. The study method, it was designed as a cross-section study participating with 251 registered nurses in two major hospitals, Qatif Center Hospital and Al Habib Hospital. And the data collection was in July 15 to September 14, 2023. The instrument was used the Brock's Quality Nursing Work Life Survey, self-reporting. So it was self-reporting questionnaires. The instrument was Brock's Quality of Nursing Work Life Survey. It's 42 items and 4 subskills. Demands home life or work life, work design, work context, and work world. So here the participant chart showing that some details about the participant. 45 less than 20, between 20 to 30 years, and 55 above than 31 years. And also 86 has dependent child, 31 has no dependent child, and 52 caring for elder parents. So here is the result. The home life and work life show moderate rate, which matching the global rate for nursing quality of life. And work design have 37 moderate and 24 high, and work contents showing 31 moderate and 67 high. Work world showing 55 moderate and 39 high. Here the compare between the emergency department quality of life and the ICU. Critical area ICU showing high quality of work life, comparing with the emergency department. Also having no children showing more high quality of work life. The significance of the study showing that staff or nurses who have no children showing high quality of nursing life, and when they have children showing low satisfaction. Regression model predict that younger staff show low quality of life, and the one have low education level also showing low satisfaction. In conclusion, moderate work-life satisfaction matching the global rate. Also, young nurses and emergency department showing low, which could be indicator for program or initiative for any healthcare system. Family responsibility also showing low satisfaction or quality of life and lower education. The research demonstrates that work environment remain strong that can be larger improve overall satisfaction across all nursing units. Connection with the Saudi Vision 2023, improving nursing quality life support healthcare transmission goal, aligning with the national strategy for sustainable workforce. Final take home, this implementation of the research will give a foundation for future nursing research and policy in Saudi Arabia, healthier nurses, safe patient, and strong healthcare system. Thank you.
Thank you so much, Ben on time. Thank you so much. The floor is open for the question and answers.
Thank you, Dr. Abdullah. I just want to ask you about the steps to improve the quality of life to nurses.
I didn't have any recommendation or communication for the research, but other hospitals they used to have some program to support that. And in the study, we mentioned that younger nurse need more support. They show lower quality of life. So other hospitals have residency program or transition to practice programs, give more time and support for the internet, or also staff with family or child. Some hospital or some healthcare system, they have some programs to support flexible schedule or in the contract they give a budget in the budget school for kids and also in the agreement for flexible shift they give them some priority.
But I think the younger nurses with low stress, the turnover problem will really, after 10 years, the younger nurse will become older, okay?
Right.
So the turnover will continue.
So this also could be included in some training for coping strategy, stress management, and proper procedure before they start class.
I mean, the inclusion criteria in the study included the age of nurses.
Yes.
According
Yes.
divided into groups.
Yes. So it's split. The one they just hire or new grad have low quality of work. So usually when they're not competent or not satisfied with the practice, this is the result will show. But when they have transition to practice program like 6 months with the facility with senior staff to supervise, they usually have more or better satisfaction.
We need another research from you, Doctor, to the dentist.
Thank you.
Okay, thank you.
Yeah. Another question. We have a question. Let's go for it.
Thank you for the fantastic presentation and study. And I had a question about the user culture. So you analyze the demographics in terms of age, but how did you incorporate, let's say, different cultural background and other differences in the 230 candidates?
251.
How did you analyze that?
So the instrument have four demand or four different subscales to measure the what exactly low and high in the staff. So first one it's about the work design, and the second about the work context, like the environment, the teamwork, and the third one it's about the work world, like the comparing from the staff perspective, comparing his job with other job in different hospitals. So it's major overall the satisfaction and the quality. Thank you. There. Very good. One more.
Next, we are delighted to welcome our exhibitors, Dr. Abbas Shiri and Mr. Gray Cho from Korea RF Lesion Generator, South Korea. They will be conducting a workshop titled Endo with Innovation in 2023, Endodontic Treatment Within a Day. Please join me in extending a warm welcome to Dr. Abbas Shiri and Mr. Cho.
Thank you. I am Joe from Korea. This is a RF technology machine for endodontic treatment. Okay, I heard good things from Dr. Rena Eva Dean. So yesterday, Dr. Rena Eva Dean said 75% pain and 50% fear for dental clinic. One of them, endodontic treatment, generally, we need to visit 4 or 5 times to dental clinic with the pain and the fear. It's a children to adult, same, because of there is pain anyhow. But with our U-Wind endodontic treatment system, and we can treat within a day. We can do it, treatment, within a day. Our Korean doctor do this one, 1 day treatment. It's an unbelievable situation. So, but the only Korean doctors knows these days, because of the we are not sold to another country. But now we can sell. Indonesia started, and this means we can reduce their pain and the fear within 20%. I think within 20% means 5 times have to go hospital, but 1 time enough means 20%. My idea, but the dental doctor will think maybe more or less. This equipment started from Japan 17 years ago. It made, after that, they sold to Japan market maybe 15,000 sets. After that, Korea also started the same. After that, we, after Korea developed 2 years ago, made this one and developed and tested and accumulated their data. We sold approximately 700 sets within 2 years in Korea market only. So if you want to treat fast and reduce the pain with your teeth, I can arrange Korean doctor for you in Korea, or another way is you can suggest to buy or show to your doctor this endovis. Now I have started to sell another countries. This is our key doctor's result. This is our key doctor's result. Please enjoy happy endodontic treatment with the fast and reduce the pain and fear. So
You can also do it from the
so
laptop.
laptop.
It's fine.
Okay, so it is up, down. Okay.
Next.
This is our key doctor, one of key doctor, but we have 700 doctor in Korea. Totally, we have 16,000 clinic in Korea. But one of them, he is made lecture for doctors. So we will make a doctor's course for training, because all over the world we need to train, teach how to use this machine and how to reduce pain and fear. So this is a greeting from him. So I saw sound, sound. It's sound need. Sound. No. Up. He's from yes. This one.
You have to scale.
Sound. Okay. Sound up, please. It's up.
Clear.
What's wrong?
Tapping the something.
It's working, so
It's fully configured.
it's video this one.
And volume is on.
Yeah, volume on.
Yes. So
And it's playing.
Something wrong in the pleasure meeting. First of all, I would like to welcome all that who have my name is John Kim. Presently want to complete background in horror and exploitation survey. And want to conservation. Our mission provide a comfortable environment and a high quality care communication and like all in the department for our mission. And will deeply not a lesser part really and usually measure and maintain life for multiple times. Therefore, even though I don't think of life, I have always here to grow. Although I'm not really from Mandarin, I would say to share so much for very challenges people come with basic text. Solutions we talk about are truly valuable and be shared with our public face can show that and also I know particular restriction by flying very famous in others in the absolutely not. And also, and in the more and I sincerely hope that this technology will as well and who may have struggled with the I feel is a sector these Congress opposed to, but it's harmful. It goes affect words country. I hope we can get a time where it can share all these tendencies and we'll together and for it. Once again, I would like to express my deep gratitude to you who you care space such. Hopefully, please so you. I hope this will bring new confidence, especially something, and meaningful inspiration. With your very painful terms. Very, very much.
It should page down. What's going on? Page down. Okay, so this is logic for the radio frequency. There is a lower frequency to higher frequency, but we are using high frequency, 3 megahertz to 30 megahertz among them, but the ours is lower. And we have 500 kilohertz using, but the hand mode we have depend on the treatment of pulp extirpation, hypersensitivity, gum whitening, mass gingivectomy, many, and even if apex over, we can treat. What the? Right, what? Yeah. Okay. This is hospital. This Indonesian doctor training from his hospital. And okay, technology on our booth, we prepared for explanation. So maybe all person can visit our booth over there and ask us more. This is hard to explain. Before this one, because of with our machine, we can treat re-endo case also. Endodontic treatment successability will be 80%. It means 20% patient complaining to doctor again. It's many headache. So doctor also hear about this complaint. So you can see that this case, doctors understand well done from this one treatment and case. So it's a treatment with the other hospital and pain and something smells. So he treat step by step and showing result. It depends on the date he collected the information and explained. Number 70 case, 27. It's for me very hard to explain, but doctors understand, I think. This is what is Japan, some study. You know, the Japan, Italy, USA, doctors studied cauterization, RF technology, but there is two types. One is continuous RF, another is pulsed RF. So we are using mixed one. It's our technology. It's a result. Result means clearly something end of there, clearly sealed. This accessory canal, they want to explain accessory canal. Our doctor says they didn't, because of the general method is that they are using sodium hypochlorite. It's all over the world they are using sodium chloride, hypochlorite. But in the case they didn't find the result, but after this one they found a new result. Because of the accessory canal, like connected canal also is sealed. This one was also he will show to doctors how before he didn't. After and with he can treat like this one. It's accessory canal is sealed. You can. This is proud of the doctors because of before they didn't, but after and with they can treat with this result. So this is re-endo procedure. We can go to hospital 4-5 times for just endodontic treatment, but the endo means again, it's more headache.
So, Mr. Cho, 4 minutes.
4 minutes, okay. Removed. This is technology. And also the burden of the doctors reduced because of the system made. It's a C-shape. Also, C-shape is you can drilling with a nitrate pile, but the C-shape, how they can do it with our endoids easily made. It's good result. Yes, Japan study. Yes, Indiana, USA study. This is our enemy, Enterococcus faecalis. We have to kill this one. Without this one means that make re-endo. We have to visit hospital again. But we tested this the microorganism killed 99% of with our system. Okay, this is how to working. You can see the boiling. This is a very small place, so the energy limited. This one we have to remove clearly with the microorganism together. This is our technology. So we have a training course for doctors all over the world. And now the Indonesia doctor finished, and then maybe Vietnam, and in the India, Ahmedabad Cheers Hospital maybe will make training center. Remove and filling, empty shell. This is Italy. Italy doctors studying for the RF, but I explained again, CRF, PRF, and generally they are using CRF. First, continuous RF means more powerful, so, but we made mixed one is more safe. And many cases in the YouTube or doctors, and we have also information. This is one of the result. Thank you. And I hope to our doctors and visit our booth and sign and explain over there our information more. So all questions over there. Okay, please ask me and Dr. Shiri more and more over there. Okay, this is will reduce your child, adult, everybody's pain and fear. Okay.
Before we open for questions and answers, please, if you have any questions.
Thomas? Thomas? There's a gentleman system in USA in the publics. We know that system, and it's also I don't put it a day, and it is also filling system. So I think your system works like as it the gentleman system.
The USA means raise system. You mean raise is okay. Our price is maybe $20,000 less than. So the end of this December, maybe version 2 will be ready. For the irrigation, we need to check the work length. Occurrence means with root rejects, we can check the root rejects and the irrigation together. So we will put it together and the new system. Also, maybe we will make price maybe $20,000, $25,000. But the razor is over $100,000. It's big headaches. And plus, yeah, razor is going straight. How they can move to accessory crown? But okay, I have seen their video. But the working style and it is out from the accessory canal and the connected canal. You can agree. But ours is RF energy. RF energy, limited energy. This one, RF energy is mixed, limited area, but the teeth also limited area. So near here, we're killing by RF energy. Okay, but our good point, cheaper, effective. Thank you. Good question. My plan, I need an American partner. I hope to make a factory in USA for the, okay, I can put it a little bit expensive because of the USA is more higher area. Even if $30,000 is cheap there, okay? Ask me, I open. Money here. Thank you. European big problem. What the problem? European made MDR, CMDR. So it means basically 200,000 euro plus 2-year need. It means European customer have to wait with strong something, yes, regulation. But our Dr. Shiri, my young brother, he want to trying to find a way. Maybe I have met the Italian IMQ. He visited Korea, and we discussed. We want to move earlier. We want to go there more earlier, European market. If there is a way, suggest me. Okay, I'll pay. No. Italian government sent some what is a team to Korea, so we discussed with IMQ. But if another way, suggest me. Why not? Money here, big money here. Okay, thank you very much.
Yeah, Dr. Abbas, please.
You take. Okay. Two boys. Yes, okay.
So thank you, Mr. Cho, for a wonderful presentation. Our next speaker is Mrs. Munaza Ahmed, Director of Advanced Practice Nursing from Saudi Arabia. She will present on advancing workforce wellness with nurse practitioner screening clinics. Please extend a warm welcome to Mrs. Munaza Ahmed.
After slide, yeah. Well, this sometimes works, sometimes doesn't. So page down. Okay. And I have a mic.
This is a mic, and 15 minutes, I'll give you a sign for 5. Keep an eye on you, okay?
Good morning, everyone. Distinguished colleagues, fellow healthcare providers, and of course, my colleagues from King Abdullah bin Abdulaziz University Hospital. My name is Manauza Ahmed. I am the Director of Advanced Practice Nurse in King Abdullah bin Abdulaziz University Hospital. And I'm truly honored to be here to discuss about a subject that is very close to my heart. And this is wellness of the people who dedicate their lives by taking care of others. So this is more giving you information. This is more telling you about a study that we're going to start. And yesterday, I heard a lot about nurse practitioners and advanced practice and want to clear up and tell you more about what we have been doing, not only in Middle East, but throughout the world. So this is more of information than a study. All right. We all know, as Abdullah said, the healthcare providers are a backbone of healthcare system. However, we are the most vulnerable to mental health illnesses, such as anxiety, depression, and burnout. According to WHO, there has been an increase of 25% in mental illnesses after the COVID pandemic. We are way past the COVID pandemic. However, it will not leave us. It will be in every research study. It changed the lives of all of us, our families. The ones that suffered the most were the healthcare providers who are facing these patients. Unfortunately, 1/3 of that 25% increase were the nurses. And what did they face? Was the burnout. We discuss and we talk about burnout a lot. Oh, I feel burned out. Oh, I'm burnt out. There are pictures that show nurses sitting down, as Miss Fabiana showed a picture of a nurse sitting down in her scrubs, tired, exhausted, hopeless, right? But what truly is burnout? A quick definition: burnout syndrome. It's actually a diagnosis in ICD-11. And if you meet 3 criteria of this burnout syndrome, that's when you get this diagnosis. So just clearly saying burnout does not mean you're burnout. There is a screening tool that's very specific to burnout, which I will also go over and discuss briefly. What is burnout syndrome? That's the diagnosis. Work-related psychological syndrome resulting in chronic occupational stress that has not been managed. Okay, that's the important part. It's the occupational stress that has not been managed. This has 3 dimensions of burnout that qualifies someone to be diagnosed as burnout syndrome: emotional exhaustion, depersonalization, and reduced personal accomplishment. And you're thinking, what is that? I feel like I'm emotionally exhausted after a long day. So I'll give you examples of what that actually means. There was a study done, this was systematic review, that showed global prevalence of nurse burnt out. And the 3 dimensions I already mentioned. So quick, this should be 0 in the real world, right? This is global. What's the population of the world? Anyone knows? Anyone? 800 billion. 8.2 billion, right? And if this was conducted in the whole globally, 33%, anyone good in math? A little more than 2 billion, a little more than 2 billion. That's a lot of people, right? 33 is like, oh, we didn't meet 50%. Oh, we don't want to meet 50%. We want to be zero. So what does this mean? I'll give you an example of emotional exhaustion. This is a nurse in oncology unit. Oncology is cancer, right? Cancer-related unit. She's sitting, takes care of the patient, goes in their room. This is what she's feeling in oncology unit. Why? The patient population, pediatric, coming in, they don't have hair, missing eyebrows, eyelashes, coming in for chemotherapy, radiation therapy, nausea, vomiting, diarrhea, look sickly. This is what's being faced by those nurses. Depersonalization, what is that? ICU nurses, critical care nurses. What does that mean? ICU, beeping alarms. Patient is on a ventilator. So many drips. Oh, we're doing CPR. How do they survive the daily stress of that? By separating, detaching. Oh, no pulse, CPR, bed flat, backboard, let's start CPR, right? If all of us, imagine, we have some critical care nurses here, imagine if you took each person as your father, your mother, your sister, would you be able to do CPR on them? So this is what happens. That's what depersonalization means. Low personal accomplishment, which with the category of people nurses that fall in this, nurses who've been in the career for a long time, maybe closing to their retirement or maybe 10 years before their retirement age. What have I accomplished? What am I going to do? When I retire, what am I going to do? I don't feel accomplished. What's next for me? So these are the category. And this is, you see, we can apply that. Either a dentist, your surgeon, your nurse. Just imagine and put yourself in this. It's really, really unfortunate, but this is the reality. Being in Saudi Arabia, so I've actually studied, lived, and worked majority of my life in the US. But this is not about US. I'm here now. This is the Middle East. I am in Saudi Arabia. So how are we going to tackle this burnout here? I'm going to give you some more information about that's pertinent to this region. There was a systematic review done as well in the region, which include the MENA region. And it said 40 to 60%, it's a little wider range, of people who were suffering burnout. And this included dentists, surgeons, physicians, and nurses. So this is a range for all medical professionals. There are multiple research studies that were done in actual cities in Saudi Arabia, a couple done in Jeddah. There was a city in Jazan that's close to the Yemen border. What was the point? To find out the burnout. Really, if we know the issue, we need to do something about it. So the purpose of these research were to find out what is causing these burnouts and what are the number of people who are facing the burnout. Workplace stress related to anxiety and depression was one of them. Of course, workload shift patterns, and our colleagues have already talked about this in their studies that they actually did in our hospital. Burnout syndrome, this is interesting to me. This was done in Jazan, the city that I talked about in Saudi Arabia. This is supposed to be percentage. So you see the burnout syndrome, the diagnosis is low, 3.5. In order to meet the diagnosis, you need to meet the 3 dimensions. But you see, emotional exhaustion 20% and depersonalization is 62.5. So the dimension in this hospital in Jazan, it was an ED. They face depersonalization. However, they're not burnt out, but they face that one dimension. They experience that. So that's what the study was talking about. How can we make a difference? And this is where I'm going to talk about advanced practice nurse and enlighten. A lot of us use that mid-level providers, nurse practitioners so loosely, but we really truly know what we do. It is a a newer concept, but it's been in the US. The first university was in University of Colorado in the US 60 years ago. But it is a newer concept, I understand, in this area. So how are we going to utilize? There's been studies that shows randomized controlled trials. There were actually a systematic review on 80,000 research study that has been done in the last 20 years on nurse practitioner. And nurse practitioners exist throughout the world, globally. I went down to each of the different countries that listed, they have nurse practitioners. It was at least 20 countries in Europe alone had nurse practitioners. But they practice differently, depending on their license, depending on their legislations and the rules. But a lot of research that shows how the nurse practitioners will add to the patient outcomes, patient satisfaction, and how will they improve like waiting times in the ED. And there was a research that was actually done that compared the nurse practitioner care versus the physician-led clinics. And we love our physicians, we collaborate, absolutely. But the point was, how is the care compared? If we know the value of that, we will utilize them. That's the only reason why, not to put our colleagues down in any way. It's just to see. So I will show you that table. So this showed patient access, waiting time, satisfaction, chronic disease. This is one of the top hits, right? In our clinics and hospitals. Patient access in nurse practitioner-led clinics, improved physician outcome, but limited. And you know why nurse practitioners emerged in the US? Because of physician shortages. That's why. Wait times reduced, physician longer, satisfaction high, lower, chronic disease, better outcomes, standard outcomes. So it didn't say negative, it just said standard. So let's go back to nurse practitioner. Who are nurse practitioners? So there's advanced practice nursing, okay? And under advanced practice nursing, we have nurse anesthetists, we have specialists, we have clinical nurse specialists, we have nurse practitioners. Each one of them practice differently, have different prescription authority, and what they actually are doing with the patients. And that depends on the country as well and the rules. So what do? They have extended privileges. I will just talk about the one that in the US and then Saudi Arabia. So in the US, we are assessing, diagnosing, treating, running our own clinics, prescribing, managing. They can walk into our clinic, we'll alatul do everything for them. Follow up, bye. If we need to refer to someone, we will. Saudi Arabia, we have, it's like a specialty. So we do have higher privileges, but not to prescribe. Assessing, diagnosing, we're running clinics, different kinds of clinics, and we've just recently started collecting data for patient outcomes through Presgani. So advanced practice nurses are mostly registered nurses who have furthered their education by doing master's degree and extensive training along with the physicians. The specialty would be ranging from pediatric, adult, it could be surgery, it could be general surgery, it could be any specialty, endocrinology, cardiology. They work along collaboratively with the physician to provide best care for the patient. So our purpose and our aim is to infuse, so how are we going to connect the wellness with the advanced practice? Knowing that advanced practice has globally shown to improve patient outcomes, decrease mental illnesses, decrease depression rates. So how are we going to utilize them? Wellness program. Think of it as an idea in your clinics, in your hospitals to take. Maybe hire and invest in advanced practice nurse. We are more expensive than registered nurses, less expensive than the physicians. right in the middle. So see if we can be invested. So how are we going to help? Quarterly screening, utilizing the screening tool that's for burnout, depression, and anxiety, and monitor and follow up. But who do we want to target? Employees. We have to care for us before we can care for someone else, right? I'm quickly going to give you overview about the screening, just so you have an idea. And you're wondering, okay, so we're going to do the screening. They come in the room in the clinic. Okay, let's do the screening, the 3 screening, they did it. Then what? What does advanced practice nurse do after that, nurse practitioner? Well, I told you we assess, we diagnose, refer, treat. We're going to refer them to the right specialty. Patients sometimes come in with mild depression. Do we say just go home? Maybe in a busy family medicine clinic. Okay, let's do your labs and then we'll follow up in a month and just let me know. No, we'll refer you to therapy, early intervention, right? So that will come out of these clinics. Early intervention, referring to appropriate discipline, psychiatry versus therapy, cognitive behavioral therapy. What does this person actually require? So this is the short Maslow burnout inventory. And look, read it. Emotional exhaustion. And I gave you examples of people who suffer, right? Keep in mind, oncology nurse, ICU nurse, older nurse who's nearing retirement. Look at this. I have fatigue when I get up in the morning and have to face another day on the job. Working with people all day is really a strain for me. I feel emotionally drained from my work. Depersonalization. I worry that this job is hardening my emotions, me emotionally. Meaning I have to do CPR, I just go there, do CPR, pulse is back, I'm fine. No need for debriefing or anything. I'm good. Because you've detached. Personal accomplishment. In my work, I deal very effectively with problems of others. I have accomplished many worthwhile things. So this is actually asking if they feel this way or not. And the ranges, the scale is here. 0, never, everything. But you see, and then in our lives, we have come across these questions in our mind, right? But it's how we're going to deal with this. The PHQ-2 is a quick screening, depression screening. Have you been feeling down, depressed, hopeless? Have you lost interest in things that you would do in the last 2 weeks? Simple 2 questions. GAD is generalized anxiety disorder. It asks about how they, if they have palpitations, are they feeling sweaty? Are they feeling anxious? Very, very specific, right? Depression, anxiety, burnout. The 3 most common mental illnesses the healthcare providers are facing. What is the result? We are expected to decline the burnout, the mental illness, and anxiety. This is a new concept. I don't have the data to show that how it would affect, how it will improve, but we have to start somewhere. And this is the beginning of that. So our goal will be, by addressing burnout, depression, and anxiety, APNs not only safeguard the well-being of staff, but enhance patient safety. Embed APNs into wellness initiatives to represent forward thinking that strengthens resilience, promotes retention, and aligns with the Saudi Arabia's 2030 goals for healthier, more sustainable workforce. Thank you. I love this quote. As you grow older, you discover that you have 2 hands, one for helping yourself and the other for helping others, right? Thank you so much. Thank you. We were right on time.
Thank you so much. So thank you, Razaima, for a wonderful speech. And of course, we all know that we are suffering from burnout and stress and anxiety. One point of time, whether it's due to, of course, burnout is related to the work-related stuff, but anxiety, depression, and all these things are actually the environmental factors, be it personal relationship or financial issues. But it was a very, very enlightening talk. Thank you so much.
Can I say one more thing? I know I'm done. If you are feeling this way, please reach out. Reach out to your family physician, talk about it, see, I feel burnout. Please don't suffer in silence.
And also, if you have any questions, please. Any questions?
Thanks so much.
So, it's time for a short coffee break. And also a group photo outside. So please go to the foyer for the coffee and of course a group photo. And we'll be back right away after 15 minutes because we need to resume our session. Thank you so much. Thank you so much. Well, great speakers, all are on time. Thank you. Thank you for making this so smooth transition.
Yeah.
Thank you.
Please join for the group photo.
I'm gonna do this.
It's okay.
Something I need to go really from my head. Okay. Will you? Yeah. أنا متفق. Because one thing, they will give this one to you, right?
Yeah. Yeah. She's one. Yeah. She's one. No. Ten to ten. Yeah. This doctors always not coming back. She's not there to us. That's why you're going to commission of it. She was almost done. And this person is serious. I don't know, she told me. You think? They come or something like that. Just know if he was sitting with me. Oh, you said? If I don't know. So who's present here? Yeah. So next is her. Only that she's not there. I don't know. Mine is over anyways. Our English. Need to say that. We can arrange. So saying our thank you. Salada. It's അതേ ഹാബിറ്റ് അവർക്ക് നല്ല ഡ്രൈ അല്ലേ അഞ്ചില് I think for medical field,
Very hard. Nobody thinks about it. Yeah, all of this trends. Sorry. From the question. So, how, what, the main working. Stay. I know, it's not. And, stay. Where is this? Yeah. Other patient. Education, crazy. Stay. That's it. What's the book? Yeah, French. Yeah, I always try. I'm trying. I'm trying to do one thing. I'm trying to make work. It's on the thing on. Main focus. Main focus. Who's your friend? Yeah, something. Yes. I want to. Yeah, of course, you should say, I'm certainly. I'm saying, thank you very much. I was a big thing. What is you? Basically, yeah, that's right. I will especially now. And it's a person, I'm interested in my So this specification yes, you still have them. Yeah. And you say that it's always better for so sharing a session and say that I'm moving it out. Yeah, please try to answer it from you yesterday. I'm the beginning actually coming from short. So we stayed with that's from short. Too much. I guess staying in Dubai, it's getting more house. So we decided, I'm supposed to be at a later. Almost started. So, I will reach here at room 8:40. You are residing at the bottom. See, from Sharjah bound, I come for my duty. I've been announcing for secretary. But now. That's okay. Yes, yeah. Although she coming to share,
Almost 400 acres to reach your height. So no, well, I've even coming from Charlotte, this national branch. And I saw there, it's how long? You just please half an hour. Yeah, to not move my back. So I can't imagine. Yesterday, I received the warning from this conference to be on time, then chairperson has to be near the time. One of the numbers, we can call the next week. Yeah, I'm like, what are the measures? This is the really lovely. Very honest. It's not easy, right? I don't care for it's everywhere. It's centralized. Yeah, it's controlled by. Is this controlled? Yeah. Morning culture. And I don't want to be, you know, okay. Exciting. Yeah. Four months. Check it out. Yeah, put your from the hands of little, the man was so hard. So, so one is in the office, one, yeah. You can just take it experience. Yes. Fine. So I is a reach and the boxes. So guys, it came at 8 plus after 8. You want, you can come see children X-ray and once you see the X-ray, if it's coming over. Yeah. Let it come whenever you want. I think no, when it's already gone, the clarification is done. Whatever you do is that. That will look. Children like this. Only after the long time. Very child. For consultation. Yeah. Yeah, yeah. I have it. It's so good. You should have. Or something or try. The area is difficult. To move from the yeah.
Wow, no drill, all thrill. Okay, okay, pediatric. Yeah, yeah. Yeah, because my son is 7.5 and his incisors were gone like 5, 6 months ago. One of them has sprouted, of course, it's half down, but the other one, I mean, it's not even sprouted, nothing. It's been almost 5+ months, so it takes time.
6 to even 18 months differences between the
Ah, okay, yeah. 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 Because our dentist there told us that it takes 9 months even for some kids. So it's okay, it's okay. And we keep on popping, eat calcium gummies, eat, drink milk, and all that. Exactly. Exactly. Pomegranate is something very good, which, it's so good. Yeah.
I need pomegranate.
Yeah, we'll start. Can you go? I mean, shall I call or?
Let me try.
Sure.
Even in
Hello. Hello. Good morning. We can just back for conference. Hello. We can join back for the conference. Please. So let me start. We'll come back. So, so welcome back, everybody. After the break, after a small coffee break, we will begin with Dr. Suhad Rustam, pediatric dentist from UAE, and her talk is titled No Drill, All Thrill, the Silver Solution to Tiny Tooth Troubles. I think the title is very, very interesting, rhythmic, and I would love to listen to her talk. Please welcome Dr. Suhad Rustam. Thank you. So you'll have 15 minutes. I'll give you time.
Okay.
Just 5 minutes.
So thank you for the introduction. I'm excited to be to be here today. So should I start? خلاص أيوة. Okay. Or should we wait? من فوق. Yes. Okay. Okay.
Yeah. No drill, all children troubles.
Yes.
Sorry, okay. From UAE, and her talk is titled No Drill, All Thrill, the Silver Solution to Tiny Tooth Troubles. Please welcome Dr. Suhad Rustam and Dr. Suhad, stage is all yours.
Thank you. Thank you, Doctor, for the introduction. I'm excited to be here today and share with you a topic that's dear to me. So, as the title says, No Drill, All Thrill, the Silver Solutions to Tiny Tooth Trouble. We use this simple solution to manage dental caries in children in a positive way, painless, effective, and without any injection or drugs. So, okay. So this is my dental path, and I'd like to share one fun fact about me. Self-proclaimed tooth fairy, but I have a soft spot for chocolate. I'm chocoholic. Okay, and here is the content for my presentation today. And before we dive into our topic, looking at these faces,
and turning the attention to the kids we see in clinic, looking at these faces, so how would you feel? So how many of you feel happy today? Raise your hand if you are happy. Excited, yes. Tired, maybe? No? Okay, that's good. Surprised? Anyway, no one is allowed to be sleepy. You just had your coffee. Okay, so children like us, they all come into the clinic with emotion. And when we, as pediatric dentists, it's our role to guide them to leave the clinic with positive experience, and we try our best to make them leave with a smile. So one way of doing this is using minimal invasive approaches to manage their caries. So the real issue is here the early childhood caries, which is a persistent global challenge we face as all dentists, not particularly pediatric dentists. As we can see also the untreated dental caries, the prevalence of it, it's very high. Even the mean ECC prevalence worldwide is high. And it's not just about teeth. It has significant impact on general health, social well-being, and educational opportunities. And the limited access to the dental care and the high treatment cost is really makes it even harder to tackle. And traditionally, we are used to drill and fill, and now this has, over the years, we have shifted to disease control and prevention, where we emphasize on minimal intervention dentistry, which is patient-centered, evidence-based, and focused on preserving tooth structure and managing caries non-invasively. So this is the highlight of our topic today, the silver diamine fluoride. It's a simple silver solution where it was used first in Japan to treat actually tooth sensitivity. And it gained its global recognition as a key MID tool, and it's ideal for pediatric patients, special needs patients, anxious patients, and it's minimally invasive, cost-effective, and easy to apply. It is strongly supported by science. It is WHO listed as essential medicine for oral health. It is FDA approved for managing tooth sensitivity, but which makes it used as off-label for caries management. And a recent study by Fontana et al. Confirmed that SDF efficacy in arresting cavitated lesion in primary teeth and root caries lesion in older patients. So what is silver diamine fluoride? It's a colorless, odorless topical agent used in dentistry, again, to arrest caries, prevent the progression of caries, and desensitize hypersensitive teeth, but it stains the teeth black. It's composed of silver, fluoride, and ammonia. And the most common formulation is the 38%, and it contains high concentration of fluoride, as we can see. This is how it stains the teeth black after applying it. So how does it work? The silver ion, it has the antibacterial effect. It disturbs the bacterial wall and the DNA. It also penetrates the dentinal tubules and form precipitate that will occlude the dentinal tubules, so it will affect also with the hypersensitivity. The fluoride ions, as we all know, it enhances remineralization and by formation of the hydroxy fluoroapatite and inhibits demineralization, and the ammonia acts as a stabilizer. And the outcome, arrested caries, harder dentin, and reduced hypersensitivity. So the indication, again, it's usually primarily used for multiple active carious lesions, especially in primary teeth. Teeth should be asymptomatic, and sometimes we use it in case of non-restorable carious lesion, but until we wait for the exfoliation or the definitive treatment under GA. And looking at the patient's factor for young, again, pre-cooperative, special need patient, high caries risk population, and patients with financial barriers, as it is affordable. And usually also we use it in case usually it's like an interim or palliative treatment until the definitive treatment of the GA or sedation. And we also use it to support behavior management. Contraindication, absolute contraindication, allergy to any of the components, especially silver allergy, but it's rare, and fluoride and potassium. And also we cannot use it in deep caries that is reaching the pulp with exposed pulp or ulcerative gingivitis and ongoing lesion not responding to SDF. So we can apply the SDF, but in the follow-up, it's still active. So it's like no use of using it. We should shift to other modalities. The advantages, again, it's non-invasive, painless, minimal cooperation required from the patient, to stop the progression of caries, help remineralize affected teeth, and even the adjacent teeth. It can be treated it can be a treatment of its own, on its own. And again, for special need patient, medically compromised, those who are at high risk of caries, and reduce the need of anesthesia. It's also saves chair time, it's affordable, and it's also used for community outreach programs because it is portable and easy to carry and easy to apply. The disadvantages, the main disadvantage is the permanent black staining, especially on the anterior teeth, because it is, this is in the front of the teeth. And it stains anything it comes in touch with, skin, gingiva, clothing, countertops. So usually clinician, we call it as SDF tattoo. It looks like henna and it fades. Within 2 to 14 days, it fades. And also it causes soft tissue irritation. Usually it's mild, it comes like as white or gray lesion, and it's self-limiting within 48 hours. And usually the soft tissue irritation comes from the high pH of the solution. So some formulation comes with the high pH, like 13, and usually the lower pH ones, the 10, it's okay. I didn't face any soft tissue irritation, but staining, yes. Taste, it has bitter metallic taste, so sometimes children find it uncomfortable, and it required multiple repeated application, regular follow-ups. And it is not definitive restoration if we need to restore form or aesthetic, so it will need additional treatment. And parental acceptance is challenged. They were not, well, they accept, but the majority, according to studies and report, they don't accept it, especially for anterior teeth. So going to preparation, informed consent is the key. You have to explain to the parents the procedure, the outcomes, how the teeth will look like. We prefer usually to show them before and after photos, and like inform them that it might during the application, if it drips, it might stain the clothes or the skin. So we prepare the patient with the drapes, gloves, gowns, and we should handle it with care. Especially when using it, we should drop it in a plastic dampened dish, not metallic or glass, because it corrodes them. And again, take baseline photographs. This helps you to follow up and assess the lesion. Okay. So the application, it's simply dry, apply, and say goodbye. We clean the lesion. It's preferable, but it's optional, not necessarily. We isolate the tooth anyway, cutter roll, dry angles, rubber dam, and we protect the lips and the gingiva or the skin sometimes with petroleum jelly or any barrier. But the Vaseline on gingiva, it's actually not essential. And I personally now, with the expert experience, I'm not using it because it will affect the efficacy of SDF. It will act also as a barrier on the tooth. So the SDF will not reach to the tooth itself. And we will dry the tooth, and then we will use micro brush and in the solution, dab the excess and apply it on the tooth. Ideally should be 1 minute, but studies say from 10 seconds to 3 minutes. You will allow it to dry by airway syringe or anyway, you have to let it dry. You don't need to light cure it. And then we will remove the excess with cotton pellet. And then optional, we can use fluoride. Fluoride will seal the SDF and will also help remineralize the entire dentition. Post-application instructions by manufacturer, there is none, but usually because patients are used to the don't eat after 3 minutes, you can eat and drink. And especially if we apply fluoride, we will give them this instruction. And in case of the discomfort from the metallic taste, we will apply a dab of toothpaste or the Profi paste. It will go away. So the follow-up, the initial follow-up should be 2 to 4 weeks, where we check the lesion for if it is arrested or not. I will show you how we assess for it. And then in each follow-up, we will assess the lesion, if it needs reapplication or not. So the frequency will depend on the high caries risk and the lesion activity. And usually if we will not go for restoration later, we will advise twice yearly application. And again, we will combine it with other restorative treatment where we need to improve function or aesthetic. And we should maintain preventive care. We should reinforce oral hygiene, dietary counseling with the parents, and of course the daily brushing and the regular dental visits. How we assess the SDF traditionally by visual appearance. We will arrested enamel will look, as we know, shiny, and the arrested dentin after SDF application, it will be darker in color. And now preferable to use the tactile features using the ball end probe. So the enamel will be smooth and the dentin will be hard. And of course, taking photography is an essential tool for assessing the caries. And for MIH tooth, since we use it for MIH, sensitive MIH, we can use the air blast test to see if the patient still suffers from any sensitivity. So SDF can be integrated with other restorative measurements, treatments, and it depends on the aesthetic or functional or behavioral consideration. SMART, which is silver modified atraumatic restorative treatment, where we combine it with GIC. GIC will add antibacterial effect and we will remineralize the tooth, and it will usually some people might ask about the bonding. Will it affect the bond or not? The evidence is mixed. Some studies will say it will increase, some studies will say it will decrease. And if you are going to use the SDF on the same visit, you will apply, you will ask the patient to rinse and then apply the GIC, but we prefer to wait for at least 2 weeks and then call the patient for the restoration. We can also combine it with the composite restoration. Actually, according to studies, the pre-treating the teeth with SDF will enhance the bond, or it doesn't affect the bond with the composite. But again, the best result when it is applied after 2 weeks. Here, why we wait 2 weeks? Because at least we will make sure that the tooth was the caries was arrested, the tooth was remineralized. That's why we will wait. And also we can combine it with hole. It's called smart hole technique. And also in case of MIH, again, we use it for the purpose of as interim to reduce sensitivity and also for caries management. Here are some cases where we used GIC after SDF, and the lower picture where we used composite restoration after SDF application, after 2 weeks of SDF application. So this is how it will look like. It will not mask the black discoloration, but at least it is more acceptable and more appealing than the dark staining. Here is one of my cases. Baseline radiograph is also essential because we want to make sure that the caries lesion, it's not reaching to the pulp. Sometimes it's not symptomatic, but it is to the pulp. Patient is not complaining. So we have to make sure about that. Okay, and these are the x-rays and below the clinical photos. And here you can see as I was applying the SDF on first tooth, the first primary molar, it was already getting darker. And then when I went to the second tooth, it became even dark and dark. Okay, here are the photos at the follow-up. So that was the initial baseline photo. This one was after 3 weeks almost. And that was around 1 month post SDF application. And this is after I applied the SDF. So this is the smart hole technique we used in this quadrant. And for the same patient, I used the smart hole on the same visit. So I applied the elastic separator to gain some space. applied SDF, and then whole crown on the same visit. And then the last picture over there, I want to highlight some point, especially when using SDF, it can stain even the white spot lesion. So be careful when treating the anterior teeth. Here where we used it with MIH case, there are still advanced consideration where we use potassium iodide. It is used to reduce the dark staining. After we apply the SDF, we apply it for 1 to 3 minutes times until it will form white precipitate until it goes away. And then the only contraindication, pregnant women, and if the patient is on thyroid therapy. We have tinted SDF as we saw in the previous picture, blue. Usually the tint to make it easier visualization and improve the clinical handling, so because we can see it. And there is a new product, Nano Silver. They say the advantage is no black staining, but is still under research. Here is where this is a case of my colleague where she used you can see the white precipitate form. After 2 weeks, she applied, that was the follow-up. And then after another 2 weeks, she applied GIC, and then she applied, restored them with the crown. So the clinical application, we went through that, young, preoperative, special need. For the adult use, we use it for root surface caries and to reduce the sensitivity. And the effectiveness, according to studies, it has high caries risk up to 81%. And usually when we explain to the parents, we should tell them that the dark discoloration is the positive indicator for its effectiveness. And when compared to the fluoride varnish, it's actually more powerful. Annual application of SDF can be better than 4 application of fluoride varnish in a year. And here you can see more. Here I want to highlight this slide. It's very important. I got this patient. He was 18 months. Okay. The parent agreed for 18 months. The parents agreed to use the SDF. Okay. We used it. But I was very upset because despite the use of SDF, the caries was progressing. It did not arrest. Why? There was no compliance with the oral hygiene and instruction. There was no brushing, and the baby continued bottle feeding at night. So this is the main reason why we have ECC. It's bottle feeding. So that comes to we should really emphasize on the importance and engaging the parents when we discuss the SDF. They have to be engaged. They have to follow the instruction, comply with the oral hygiene. And it is accepted globally, mostly again for the anterior than the posterior, and when the child is uncooperative or if parents don't want to do GA. Here in UAE, this was a study done in UAE by Dr. Taroun. Again, majority, almost all, it was unaccepted for anterior teeth. Still, some accepted it for posterior teeth. And the reason usually for the refusal, not only the aesthetic. I found some parents who come to me, they don't know what's SDF. They don't know what the side effects of SDF. So after explaining there, it comes our role. We explain to them, and then we can use it. Safety, it is safe. Okay, no side effects. Fluoride, silver, they are all way below the toxic or lethal doses, but it is safe when it is used in the recommended amount. It is 1 drop for 1 patient per visit, and this usually will treat 3 to 5 teeth, not more, please. 1 drop for the entire visit for 2 to 3 maximum teeth, and it is biocompatible with the dental pulp. And my take-home message, again, dry, apply, and say goodbye. I know I'm almost done. Okay. And these are my suggested reading if you want to take a photo, if you are interested. And here are my references. And I would like to end this presentation with this saying, with this thought: healthy smiles equals healthy communities. Hand in hand, we nurture tomorrow. Here in UAE, the year 2025, as you all know, it's named Year of Community. So it's not our role as a dental professional. It's not only about treating teeth. It's where we build the trust and create healthy happier communities. And that's it. Thank you for your attention. And if you have any questions, you're welcome.
And the floor is open for the question and answers.
No questions? I was prepared for questions. Any thoughts, any questions? No doubts? All clear? Okay. Finish. Yes. Hall technique is where it's named after the Dr. Hall Noor or something. I don't recall her name exactly, but it's where we use the stainless steel crown without any preparation. So if we have enough space, we can just apply it. If not, either we apply this elastic separator. Sometimes within half an hour, 20 minutes, we can get the space we need, or we call after 2 to maximum 1 week, we will have the space and we'll apply it. Or something called modified hole, where we can do just a slicing of the proximal slicing, then we can place the crown.
Any more questions?
Yes. Okay. Yes.
Did we start from which age? Like 18 months?
No, from once the first tooth comes out. So that's 6 months, 4 months. Okay, practical, of course, it's not easy and not all children will accept it. Some you will find your children, if you have any of you will find they will accept, some will totally refuse. But for the beginning, you can start those silicone finger toothbrush or a gauze or a wipes, xylitol wipes. You can wipe it, even the first tooth. So when you start this early, the child will get for this sensation. And as he grows up, will get used to this behavior. Okay, this is very important point you mentioned. Brushing should be done by parents, elder caregiver, until the child is 7 years old. Usually we say until the child can tie his shoes. So the brushing is not by the child, by you. Some children, they like to play with the toothbrush. You let them do this part. Encourage them, like make it like a routine habit where the child and the mother, the parents do it together, or show them some very nice videos on YouTube. Yes. 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 No, it is not. But it's like everything you teach your child. You teach your child to eat. You teach your child to talk. So it is one of those things. But it will take time. Not all children accept it. Yani, I don't have children myself, but I see it in my niece and nephew. Some will love it and yes, yalla, let's brush. And the others, no, they hate it. They just don't want it. Yeah. Yeah, yeah. Yeah, it takes time with the videos, with the demonstration, make it fun, colorful, toothbrushes. You will reach there at the end. 2 times for 2 minutes, okay? Brushing 2 times. Any more questions? Sir?
Any more questions?
Okay.
Okay.
Okay, thank you. Can I take one order? With you. Yeah. Thank you. Thank you very much.
So, thank you, Dr. Rostam, for the wonderful presentation. I would like to invite our next speaker, Dr. Unisha Vijayakumar. She is a periodontist and aesthetic dentist from UAE, and she will discuss laser-assisted periodontal therapy. So, please join me in welcoming Dr. Unisha Vijayakumar.
Thank you.
Thank you.
A very good morning to everyone. So here, I'm here to present on the topic laser-assisted periodontal therapy. Being a periodontist, periodontal therapies include everything that what you do to support the tooth supporting structures. That means other than the tooth, what is the foundation? What lays the foundation for the teeth is the interest, the topic of interest over here, and how we use lasers to treat different problems that we find within the gums, the cementum, the periodontal ligament, everything that supports the tooth. Okay. So, a little introduction about the lasers. Lasers have been in use for centuries, for so many decades, and it was a very scientific invention that took place by Theodore Maiman, who mainly told about the first working laser. So the concept was basically given a lot more years before by Albert Einstein also, because of the emission of the thing radiation that is there. So many concepts were existing before, but the first working laser was actually done by Theodore Maiman. And early development and adoption took place much later. Okay, and scientifically speaking, first it was obviously for the tooth preparation, caries prevention, and everything related to the tooth structure that the lasers were introduced. Later on, advancements came. They understood that there could be different type of lasers, different type of wavelengths that can be used for other procedures as well. That means the soft tissue procedures. That is the concern over here. And nowadays, now we have digital imaging and scanning technology that is associated with the laser, so that we can incorporate into the soft tissue procedures as well. So a little, I'm not going to get too technical about it, just about what are the different kind of lasers used usually in the dental situation for periodontal therapy. So diode lasers, very, very important. It's almost like the workhorse of the lasers, if I can say, very commonly used, and so many systems are available, so many type of tips and laser units that are available. So diode laser, every laser, obviously the difference in the properties is because of the difference in the wavelengths, okay, and the kind of absorption that will take place, okay. Over here, diode laser is 810. It starts from 810 till 1064 nanometer. It will be diode laser. Mechanism of action, basically get absorbed by anything that is pigmented. Pigmented cells like bacteria and the pigmented cells within our gums and everything absorbs this light and there is effect. That is why we use diode lasers. Basically, for so many, it's not just gingival contouring and the removal of soft tissues and all. So many properties are there. We can talk about lasers for hours and hours. Just a very concise version I put over here. So reduction in bacterial population, removal of soft tissue lesions, hemostatic effect, wound healing, and at a very lower power, we can also induce photobiomodulation also. That means healing properties, wound healing, and all those things. This is at this wavelength, it will always cut the tissues. Okay, next is a very other important laser. A little more expensive units are available in this. Is the Nd:YAG laser. Nd:YAG. It is basically neodymium yttrium aluminium garnet. That is the full name. We usually call it as Nd:YAG. Working wavelength is 1064 nanometer. Now this is also much more than diamond, highly absorbed by pigmented tissues and bacteria. Now, there is one special property at this wavelength, that it is selectively absorbed by the diseased cells or the diseased tissue. Now, how it is very much active, because diode can cut everything, or it is affected all the tissues and everything. But this specifically, when it is increasing temperature in the diseased tissue, it's a much more advantage for us. So absorption enables efficient tissue ablation as well as reduction in the bacterial reduction. Deep pocket debridement, higher penetration level is known for the Nd:YAG lasers. Lingual frenectomy.
Lingual frenectomy I've mentioned over here because again it is a very thick tissue compared to the labial frenum. Lingual frenum is comparatively a little more thick and it requires a much higher wavelength. That's why Nd:YAG is preferred for lingual frenectomy. Other classification of lasers will be erbium lasers. Two types of wavelengths are available. Erbium YAG and erbium chromium doped yttrium Scandinavian gallium and garnet. Okay, so these two are there. Just the difference in the wavelengths. YAG will be 2940 nanometer. Okay, and removal of calculus. One special property about the erbium lasers, both soft and hard tissues. Both diode and Nd:YAG, I would definitely recommend for soft tissue lasers. That means they cut soft tissue. But erbium have got this dual nature that at higher temperature they can even do so much of hard tissue. That means even cavity preparations, even removal of caries, contouring of the bone, etc. can also be done by the erbium laser. So this is an important thing. Comparing erbium YAG and erbium chromium YSGG, I would definitely say that erbium YAG is more preferred because less damage to the bone. In many studies, we have come across that erbium YAG cause less damage. Okay, we talk about the problems also that is associated with lasers. Hello, am I audible? It's okay, right? Okay. Hello. Okay, another classification of lasers will be the carbon dioxide lasers. Purely hard tissue lasers, okay, because of very high working temperature, you can wavelength that is 10,600 nanometer, often considered also for soft and hard tissues. I'll tell you the reason why it is considered like that. The thing is that it can be used in various forms. That means pulsed or continuous running. When it's used for the pulsed ones, you can also use it for soft tissue ablations and etc. And for the continuous running or the defocused wavelengths, you can use it for the bone recontouring and so many other hard tissue kind of applications are also there in this. Again, it's very famous for desensitization uses in the root surfaces. So when you're using for desensitization, what you do is hold the laser tip parallel to the root surface, not perpendicular. And then in pulse mode, when the carbon dioxide laser is activated, the dentinal tubules will get occluded by the dental smear that is produced by this. A small kind of thermal effect will be there that will occlude the dentinal tubules and desensitization is caused. So carbon dioxide lasers are also quite very famous. Only the problem is that if not used properly, technicality in the use of carbon dioxide lasers is very, very sensitive. It can cause craters, it can destroy your root completely. So only technically able dentists are supposed to use a carbon dioxide laser. Now, this classification is not given anywhere. It is not a formal classification of what is laser associated periodontal therapy. But the way I wanted to present in some of the treatment modalities that is done, I have divided into laser assisted periodontal therapy. One is LANAP, that is laser associated new attachment procedure. Laser associated peri-implantitis procedure, photodynamic therapy, and low level laser therapy. Okay, so these are the things that I want to discuss with you, which comes under this lasers. What all lasers that you use in periodontal therapy can be broadly like what are the uses, majorly what you can do, differences in the periodontics. Now, this one is very important and it was not so far ago. Even though this laser was invented in 1989, it was already seen to show a lot of promising effects on soft tissues. A very breakthrough that happened was that Gregg and McCarthy formulated a set of protocol, and this is trademarked as LANAP. Now, this LANAP procedure can be only done with a Nd:YAG laser. Nd:YAG laser of 1064 nanometer is used. and it is approved by the Food and Drug Administration FDA clearance for the only laser protocol that produces proper regeneration of periodontal tissues, including cementum, periodontal ligament. There is no other laser that has shown this or achieved this kind of a breakthrough. So McCarthy and Gregg did this, and the protocol is only indicated for periodontal pockets that is above 4 millimeter. That is very deep pockets only can be applied for this protocol. I'll just go through very superficially, because again, I told you so much is there about this. So within the confines of this presentation, I'll just tell you. First, the probing depth is measured. After that, in this particular protocol, there is no scalpel that is used, no cutting, incisions, nothing. It's just with the laser tip that is being pulled from the apex to the coronal. It is just dragged a little like that, so that like a flap, like how a flap will be raised, the flap is just reflected with the help of the tip of the laser. So once it is raised, that itself, you're ablating the diseased sulcular epithelium, the diseased pocket epithelium. Once that is done, any calculus, subgingival calculus that is there is removed. Okay, root debridement, very important, because even the tiniest fleck of subgingival calculus that you'll find on the root, attachment will never happen. No matter how much you clean, how much ever laser you apply, the gingiva is not going to come back onto the root. So root debridement is done. Bone modifications. This is optional. That is, in the X-ray, you have seen wild reflection, you have seen some kind of bony irregularities are there, craters are there. You need to modify, you need to smoothen it. You make sure that it will be allowing the gingiva to grow back. Okay. After the bone modification, a slightly higher power. That means 2 watts if it was used for just as I told you, the gingival flap racing with the laser tip. You should increase the power a little more so that there is blood clots that is formed. Voluntarily, you're inducing the blood to form so that it will clot. And this clot is going to help you with the help of a gauze. When you are going to press this clot against the tooth surface, it's going to close. So no stitches again. You're not going to do anything, physically to close this gap that is being created. Automatically, the fibrin is going to have this closing wound closure that is going to be happening. Occlusal therapy, again optional. If you see that there is occlusal interferences, there should not be any other extra forces, unwanted forces acting on the tooth, so that it will heal properly. And in 3 weeks' time, the studies show that there is completely new formation, a new attachment, that is attachment system, junctional epithelium, cementum, periodontal ligament is formed. That is what the studies have been shown. So this is the LANAC protocol, very important Nd:YAG laser that is being used. The same thing, same protocol, when we repeat it for a peri-implantitis case. Okay, that is surrounding a implant. You have an implant and it's not maintained properly, or there is periodontal issues, and the Mech and Gregati protocol is being applied, it becomes LAPIP, or laser assisted peri-implantitis procedure. It's exactly the same procedure as I told you, just that the surface over here is not the natural tooth, it is the implant. Peri-implantitis can also be treated the exact same way that I mentioned before. No, again, why this gained a lot of success is because when you tell the patient that there is a surgery with a scalpel, again, the first thing comes is, oh, so much of bleeding, so much of problems that's going to happen. Now for the stitch, again, I have to come back. So much of fear already instilled hearing the word surgery. But the moment you tell that it's just done with a laser, it'll take so and so minutes and you can go back the same day, no bleeding. That is the most advantageous thing for the patient. Patient itself will be relaxed and you can do this. Only problem is that those machines are really expensive. I have not seen in so many, except for really huge establishments or hospital system. I don't think in a normal clinic you will get to see a Nd:YAG laser. Next category of treatments that is done is a photodynamic therapy. Photodynamic therapy, as you see over here, Actually, it was invented for cancer treatment. That means when you use now S1 and S0, what you see over here is a photosensitizer. That means a pigment. You can imagine methylene blue or toluidine blue, isocyanine green. There are certain pigments, okay, the liquids probably in the dilution of 1 milligram per 10 ml. It's been diluted, put inside the pocket, and then you put some laser light. Now, what this laser light does is it energizes that particular pigment, and there is free radicals that is produced, or the hydroxyl ions or certain ions that is reduced. What these ions do is kill the bacteria that is there within the pockets. So bactericidal effect is there. So just that, secondarily, you are adding a pigment so that it increases the efficacy of laser in killing the bacteria and detoxifying the periodontal pocket. Okay, so this is basically a bactericidal kind of a therapy that we can say. A lot of studies have been done. So much success is there with methylene blue. It's moreover accepted by so many people. There are clinicians I know who regularly do this, but there are some people who doesn't do this. Whatever we say, whether it is compared to the Lenap and Lapib, I won't say that it is much accepted, but it shows significant promises where you know that certain medications or even some patients on doxycycline for a very long period of time, they're still, the bacteria is not reducing. You can go for this kind of method and try it so that you can get reduction in periodontal pocket reduction in such kind of things. Again, certain effects of laser as such. I don't want to go so much in detail. So much is there to say. These organisms are the main ones that is responsible for periodontal disease. So many meta-analysis, systematic reviews showing proof, solid proof that there will be reduction of these microorganisms, resulting in resolution of periodontal disease. Even stage 3 to stage 4 periodontal disease can be restricted, the progression can be restricted by using lasers on a regular basis. Regular basis means some patients might require multiple visits. That means every 3 months, every 6 months of laser treatment to make sure. Clubbed with decontamination. That means the root surface should be cleaned and then laser therapy should be given. Periodontal cell effects, you should understand that these are the cells that are majorly involved in the wound healing, in the periodontal pocket, macrophages, osteoclasts that is there, that will destroy a lot of bone structure. Then the lymphocytes, which is helpful. Actually, it is an innate immune system, right? So whenever there is damage happening, so much of lymphocytes are there to help you out in increasing the kind of tissue formation within the pocket itself. So all those factors are affected by the laser therapy. Clinical outcome, there is the reduction in periodontal probing depth and increase in clinical attachment level that is seen. Host immune response is much bettered with the help of laser, and the bacterial composition, especially the major pathogens that is involved in periodontal diseases, very significantly reduced with the help of lasers. Last, coming to low level laser therapy. Now, this is also called a soft laser therapy because usually till now, what all lasers I discussed about, it's actually about cutting or cell ablation is happening. You're literally burning the tissue or you're cutting. But in low level laser therapy, the wavelength is reduced so that the heat effect that is produced is very, very minimal. So it doesn't cause damage. But what it is causing over here, you can see that the temperature of activation is as low as 55 degrees Celsius or even lower than that, so that it is only you're modulating the cells over there. You're not trying to kill anything, you're not trying to cut anything, you're just modifying the cell. More explained by this. When the light falls, there are certain changes within the cell organelles inside the cells of the tissues that you're doing, so that in the more cell proliferation will take place. That means after a flap therapy, you're doing a low level laser therapy. That means about 600 to 700 nanometer of diode laser. There are tips specialized for that. It will be a little more broader kind of a thing that you'll point towards the area of the wound in the oral cavity. And when you run it in a continuous mode for about 40 to 50 seconds, there is increased amount of cell proliferation, motility, and growth factor. It will help in the wound healing. You're helping it out. Yesterday, I remember hearing talk about the low-level laser therapy in the TMJ disorders. So it is similar to that. You're trying to increase the cell activity over there so that it brings about healing, wound healing, and how you're going to go about it. Clinical outcome, again, there is decrease in the plaque index that is seen, clinical attachment level is improved, and pocket probing depth is also improved. And the surgical therapy, it is always reduction in inflammation, improved repair, and there is reduction in pain also. All these clarified by the meta-analysis and systematic reviews over the period of time. Potential risk and side effects, it's always about the heat. When it comes to, as a person who has been using lasers, I always feel that the heat control is very, very important when using lasers. Continuous irrigation, thorough saline irrigation during its usage, making sure that the settings are correct. There is always a tester dose that you have to do on a piece of black paper that you get along with it. You need to test it first and then only do it on the patient. Because, and the way you're using it, it should not stay at one point for more than these many seconds because it will cause more damage. We have structures like root, bone, etc. there. It can undergo permanent damage. That means the temperature that is created for that particular point in that particular second is too much that it can cause a lot of tissue necrosis. So be careful because of that. Technical difficulties are the most what it comes to the disadvantages or why there is a risk of using laser. Then, of course, the eye damage, the protective eyewear and everything that should be there should definitely be taken care of. And post-operative bleeding, mostly it is not a very big problem, but when you're doing palatal procedures or you're cutting any tissue from there, or for grafting you're trying to take a graft from the palate and you cut a major artery or something like that, there is a small risk. But with the diode lasers itself, you can actually hemosynthesize such kind of cuts or difficulties when it comes to doing soft tissue procedures. Contraindications, again, as I told you, qualified dental personnel should be responsible for doing such things. Patient's medical history is very important. Any systemic conditions or anything that is ongoing and the patient is contraindicated, you should have a referral from their medical doctors. Then the potential retinal damage if not using the correct kind of protective eyewears and everything, overheating problems that is there, infection control, every part of the laser system that is being brought into the mouth and including the protective eyewears, etc., should be regularly made sure that it's protected from infection control procedures are followed. And of course, during for patients with pacemakers, pregnancy, and photosensitive medications who all are undergoing, should make sure that it doesn't cause any other problems like interference in staining, teeth staining, etc. Emerging trends. There are certain studies regarding combining the comprehensive kind of a treatment with laser with digital imaging and 3D imaging, etc. So that we will get an idea of exactly how it is beneath. Like when you're getting, it's like taking a CBCT of your oral jaw and then planning for the procedure with the laser. So such kind of things are underway, and then customizing the laser wavelength according to the genetic profile of that particular microbiota. In some individuals, it might be that one particular periodontal pathogen which is very resistant to any kind of antibiotic therapy that you need to treat. So for when you individualize for such kind of patients, that becomes a very important thing. Comprehensive approach is always preferred in the laser management. That is, along with scalpel treatment, if you can use laser as well, it will become obviously a very successful treatment because what all shortcomings are there of a scalpel treatment, it can be overcome with the advantages of laser. Then optimizing laser parameters also. Now, most of the laser systems that we have got their built-in wavelengths and the wattage, everything can be controlled for different kind of procedures. And portability is a very important thing now. Even doctors with portable lasers are in more demand, because rather than them having a clinic, the unit in the clinic, if the doctor comes with a laser, they are obviously more preferred and then more demand also. So portable systems are readily available. The smaller size of the laser systems are also readily available. So as a conclusion now, with the kind of advances that is there, AI-driven laser systems are in like in talks, in studies, what they are trying to do according to like the robotic AI managed kind of laser eradication and all. So many things are going underway, studies. Till now, there are no long-term studies to prove that it's going to be beneficial over the ones which is going to be done by the dentist, but let's see that it's going to work out or not. And like yesterday's talk, let's not fear AI, let's include it in many of the therapies and look forward to a better kind of laser implementation in so many other procedures other than not just periodontal therapy, but the overall healthcare also, oral healthcare also. These are my references, and thank you. Thank you so much for having me.
So thank you, Dr. Risha. The floor is open for the question and answers. If somebody has any question. Okay.
Very important thing that we do is crown removal or veneer removal. So you mentioned about MPM yarn, right? So this is very powerful and even tooth drilling is all possible. So is this same thing can be used for removing the veneers, crowns and all in clinical scenario?
Actually, in crown removal, I have not come across anything like this. Okay, what you can do is that these are crown removal things. What you're hearing about is a high frequency. There are machines that can have the high. Laser usually not anything related to that. Hard tissue lasers, maybe for cutting the crown or something like that, we can still something it is possible, maybe like that. I'm talking about the original crown, not the natural cutting. That is the only thing that is possible. Veneers also. No lasers till now I have not come across of these. Any other question? Thank you.
Thank you. So next we have Dr. Gulia Anfaso Lembo, dental hygienist from Italy. Her talk is titled Oral Health Management in Patients Awaiting Transplantation and Organ Transplantation Recipients. Please welcome Dr. Gulia Anfaso Lembo.
I need this. Yeah, you want to keep this? Because I have a note. Okay, got it. And I'm going for militaries. So what was this? Is it okay? And with this, you better you do this because sometimes it works, sometimes. Okay. Thank you. Good morning, everyone. I'm so very honored to be here. And I'm a Italian dental hygienist. And today my presentation concerns oral management of patients awaiting organ transplant, and organ transplant recipients. So let's start. A transplant is a surgical procedure to replace a damaged organ with a healthy one, whether from a living or dead individual. So thanks to the latest medical and scientific discoveries, the quality of life for transplant recipients is more than good. However, they are forced to undergo lifelong immunosuppressive therapy. The main risk after transplant is organ rejection, and this happens because the immune system recognizes the transplant tissue as foreign and attacks it. The reaction is triggered by the presence of non-self antigens, by antibodies direct against non-self MHC molecules, and it can also be worsened by inflammatory condition. Rejection can occur at the different times after transplant. Hyperacute rejection happens within just a few hours after the surgery and caused by resisting reactive antibodies. So acute rejection can occur up to 1 year after transplant, and it may be vascular involving CD4 plus T lymphocytes or cellular, due to the cytotoxic action of CD8 plus lymphocytes. And finally, chronic rejection usually appears no earlier than 3 months after the transplant. And in this case, pro-inflammatory cytokine lead to fibrosis of the new organ. So the complication that can occur after transplant may be surgical, and these include wound infection, hemorrhages, renal artery or vein thrombosis, urinary or pancreatic fistulas. So the other complication can be medical, and these include infection, for example, cytomegalovirus, the development of atherosclerosis, problems in patients who are positive for HB virus and HC virus, and also the occurrence of the tumors. So the minor complications are mostly linked to corticosteroid therapy, and this may include increased hunger with consequent weight gain, a risk of atherosclerosis and diabetes, osteoporosis, and even eye damage, for example, glaucoma or cataracts. So the antibiotic prophylaxis should be administered in a specific situation. It is mandatory for 6 months after the transplant. In a heart transplant recipient who developed a valvular problem, or whatever is considered necessary by the attending physician or a dentist. So now let's go to the core and analyze the oral complication in patients awaiting transplant. So the liver can be damaged for a different and several reasons. These include viral cirrhosis, alcoholic cirrhosis, viral hepatitis B or C, autoimmune hepatitis, and drugs that induce the damage. The patients awaiting liver transplant may show oral complications such as tongue manifestation, extraoral manifestation, and fungal infection. Oral petechia and increasing gingival bleeding can occur, and these are caused by thrombocytopenia. So, as for kidney need to be transplanted for a similar reason, and these include glomerular disease, for example, nephrotic syndrome, tubular or tubular interstitial and vascular nephropathy, diabetic nephropathy, polycystic kidney disease, and stage renal disease. So one of the problems in a patient awaiting a kidney transplant is periodontal disease, and this can be caused by common risk factor, bacteremia,
systemic inflammatory condition, and endothelial dysfunction. The other manifestations include periodontal infection, oral candidiasis, seriostomia, uremic stench, uremic stomatitis, erosive damage, renial osteodystrophy, and gingival hypertrophy. The other possible causes of oral complication include seriostomia and dysgeusia due to the glandular involvement, uremic stench by constant uremia, and hypotrophic and pale mucosis membranes for anemia. So in addition, it may also be found uremic stomatitis for elevated blood urea nitrogen levels. And dialysis can further contribute to erosive damage to the heart tissue through nausea and vomiting, while renal osteodystrophy caused by imbalanced calcium and phosphate metabolism, vitamin D alteration, and secondary hyperparathyroidism leads to bone change, pain, fracture, and calcification of maxillary and mandibulary bones. So now let's look at the oral problem in patients with organ transplant. So infections are also frequent, and the most common is candidiasis, which may be present as pseudomembranosis candidiasis in oropharyngeal and vestibular mucosa, palate, and dorsum of the tongue. So another form of candidiasis is erythematous or atrophic, and this can be found on the palate or dorsum of the tongue. And finally, angular cheilitis caused by the presence of Staphylococcus aureus. It appears at the labial commissure, especially in patients who wear a denture. So the transplant patients are also at a higher risk of herpes virus infection, including herpes simplex 1 and 2, varicella zoster, Epstein-Barr virus, and cytomegalovirus. So the most common herpetic manifestation is herpetic gingivostomatitis with fever, loss of appetite, cervical lymphadenopathy, and a cluster of vesicles on erythematous base. And it can be found on the vermilion border of the lips, hard palate, gingiva, and dorsum of the tongue. So varicella zoster is also often present and is latent in the dorsal spinal ganglia, and it is transmitted by hair through the conjunctiva or by direct contact with the active lesions. And it involves the oral tissues and the overlying ipsilateral skin. So Epstein-Barr virus can cause eye leukoplaky, and it appears as an asymptomatic white epithelial lesion on the tongue margins, and its presence along with decrease in Langerhans cells, and is a pathognomic sign of severe immunosuppression. And finally, cytomegalovirus remain latent in various organs, endothelial cells, and salivary glands. And about 70% of transplant patients test is positive. And the incidence is even higher when the donor is cytomegalovirus positive. And the cytomegalovirus infection can cause oral and esophageal ulceration and may worsen of renal function. Another frequent issue is gingival hypertrophy, and this condition increases gingival volume. It can be a clinical manifestation of various local, systemic, and pharmacological disease, and the enlargement make it difficult to maintain a good oral hygiene, and which increases susceptibility to oral infection. So gingival hypertrophy is often caused by immunosuppressive drugs, calcium channel blockers, and antiepileptic drugs. So it appears to 1 to 3 months after to starting immunosuppressive therapy when the dose is maximum, and it begins at the level of the interdental papilla of the anterior teeth, and then spreads horizontally or vertically. But the worst risk in transplant patients is development of oral cancer, and the incidence of malignant change range from 2% to 31% after transplant, with about 40% of precancerous lesion occurring on the lips and on the tongue, and Kaposi sarcoma may also develop often following cytomegalovirus infection or gingival hypertrophy. So now I would like to present my clinical case that I have treated during my clinical practice. This is my patient. She has 45 years old, and she's waiting a kidney transplant and has been on hemodialysis for 4 years. She presents with evident plaque and calculous deposits, generalized inflammation condition, and pain. So non-surgical periodontal therapy was performed in 2 stages. For first time I made debridement, and secondary I made scaling and root planing. And she was given instruction on how to maintain a good oral hygiene at home. And I explained the importance of oral health while awaiting a transplant. So the results and maintenance are good. The remission of inflammation and symptoms help promote the long-term health of teeth and periodontal tissues, reducing the risk of the complication we discussed earlier, while supporting systemic health. Dental treatments has to be performed by the dentist, and a checkup with oral hygiene session are performed every 3 months. He is my another patient. He has 46 years old, underwent a kidney transplant, and is taking immunosuppressive therapy. Calculous and plaque deposits are visible, but gingival hypertrophy is very evident. And he also underwent 2-stage no-surgical periodontal therapy, and was informed about the proper methods for maintaining a good oral hygiene at home, as well as the risk associated with his condition as a transplant patient. So unfortunately, the results were not satisfactory, and hypertrophy is still present. And for this reason, the patients underwent periodontal soft tissue surgery performed by the dentist, achieving a good dental and gingival health. And he also maintained program with checkups and oral hygiene session every 3 months. Okay, so in conclusion, here are the fundamental steps recommended for this category of patients. After a visit to the clinic, thorough medical history should be taken, along with dental x-rays, intraoral photos, and intraoral clinical examination. A personalized treatment plan should be then developed, and followed by the periodontal therapy and any necessary dental treatments. Patients should be incorporated into a periodontal supported therapy programs with regular appointments with dental hygienists. So in conclusion, dental hygienists play a critical role for patients awaiting or having undergone an organ transplant, who are the higher risk for infection. And poor oral health can cause systemic infection, which can become very dangerous in immunosuppressed individual. So for this reason, pre-transplant oral assessment is essential for identify and eliminate the possible sources of infection before the surgery. And after the transplant, continues to monitoring post-transplant to prevent complication and to protect the success of the procedure. So the need to provide dental care to transplant candidates is growing as the number of transplant procedure. And in the multidisciplinary field of medicine, the dental hygienists play a key role in primary prevention. So I believe the oral care is more than teeth, it's a vital part of safe and healthy life, especially for a patient at high risk. So thank you for your attention.
Thank you, Dr. William. Floor is open for the question answer. If you have any questions, please ask. Any questions? Okay, thank you. Thank you. Thank you. Yeah. Oh, I have been informed that you will present in the second session. No? No? Okay, okay. So our next speaker is Dr. Farhud Kaviani Rad. She is a general dentist from Iran, and she will speak on immediate implant placement in fresh extraction sockets. So please join me in welcoming Dr. Rad. Please. So after that, I will be giving you a signal 5 minutes before your presentation. Because we are not asking up. Okay. Thank you so much.
Hello everyone. My name is Farhonde Kavianirad, and my nickname is Nilufar. I'm very happy to see you, and I'm in this place. My subject is about the immediately implantation in aesthetic zone. All of the picture in this slide is about myself and during my work in my clinic. Yeah. This picture is my family, my father and my brother. And I think want to immediate implantation in aesthetic zone. Immediate implantation, what it means? Means when I extract the tooth as soon as possible, at the same time, I put an implant. For example, in this my patient, the central incisor will be broken, and he wants to know, he wants aesthetic from me. And I remove it, and the same session I put implants. During this surgery, it is very important about how I surgery for him. When I want to extract these roots, I should attend about the how extract it. One technique I want to say you about extraction is, in this case, it's better, and better technique is you use periodontal. Periodontal is an instrument that help you to stay around bone, especially buccal bone. When you use periodo around the root and lose it, so you use the round bear and cut necessarily the roots. And the palatal part of roots you extract, and the part of vocally you save, and with great round bear you shave the roots. And a little roots and period you save. It help you save vocal word. And in future, you don't have any problem for aesthetic, for metallic show of your implants. It's very important. And another point about this surgery is the sequence of drilling. The sequence of drilling is important, and the access of drilling. When you drill this area, if you drill access of the roots, your implants will become very palatable or become very buccal. And when your implant will be buckling, your gingiva become resistance. And when you input palatally, you don't have any good emergence profile. And then how we should do? It's better you can do the with round bear in one sort of palatal aspect of root. You point drill with bear round as one sort of ball and point just ball, and then start sequence of drilling. The start of drilling, the sequence of drilling, where about you imagine the incisal edge of teeth 1 millimeter palatally the incisal edge. You drill, yeah. And sequence of drilling, bone drilling, 2 millimeter diameter, and then until your diameter of fixture. But in first second implantation, it's very important. Sometimes we need under drilling, because when you do all of the sequence of drilling, the bone is not available, and your torque will become less. But when you have good torque, you can immediate loading for your patients. Okay? Okay. This slide is about the cause and reasons of the people needs to extract their, for example, wisdom teeth or decay. You know about them. And dispersion, the decays, excessive decays, they have remove the roots with periodon and save bone. The placement of implant is very important. For example, in posterior tooth, between the roots, intra-auricular bone is the best place for implantation. And other thing that's important in this slide is that we need at least 3 millimeter between every implant, and the between implants under the tooth we need 1.5 millimeters, and according to the thickness of the gingiva and bone, we need about 3 or 4 millimeters, and it caused the depth of implantation. What is this? According to thickness of gingival tissue. In some cases, in fresh socket implantation, we need bone graft and GBR technique. I say about it in next slide. In these cases, the canine, I extract it and immediately I place implants. In every case, I measure my patients about very important. I ask them about sign and symptom of disease because some people don't know about your disease. But and sometimes I see a sign of symptom in oral cavity and say them about your disease and find their disease. The cause of my unusual blood pressure is I want to inject the local anesthesia. Local anesthesia consists of epinephrine, and epinephrine cause hypertension or blood pressure become high. So for all of my patients, I blood pressure test for my patient. In these cases, he has a full arch implantation. I surgery for him. The between implants as least 3 minutes. Space is available. And I flap. I think in aesthetic zone, flapless or punch technique is not good because the gingiva is very important in aesthetic zone. When you punch technique, you remove keratinized gingiva. And okay, and some causes my patient needs implantation for example, in this case, missing congenital tooth in lateral incisor. I put implantation. Again, therefore, is not enough. I can use brands of implants that has round diameter or one piece implantation. Some brands has a one piece implantation. It's good for this slide, or diameter about 3 millimeter. It's good for lateral incisor or lower jaw anterior. It's very good. Another, and for impacted tooth canine, it's good. It's my patient, and another, the position and sterilization and the path of insertion is from and I remove it and put implants immediately. And if I under drilling for them, I can immediate implantation. I GBR for him. And about crown, cemented retained crown is and restoration is better because less pre-implantitis. And sometimes we need kind of tissue graft, and periotom is better, and I check occlusion, GBR, and the flap is very good. When you sharp design flap, it's very good. Not punch technique just for low bleeding. Okay. And direction and angle and position of implant is very important. At in the anterior, the tape position is good. It's actually running taper. Multiple brands exist about implants, and when you do the good technique and good instruments, your patients and even your assistants will become satisfied with us. I like my work. I enjoy my work.
Thank you.
Thank you very much.
Thank you so much.
Thank you.
Thank you so much, Dr. Ram. Questions? Okay. Thank you. Thank you so much.
Thank you. Thank you.
So before closing the morning session, we have our keynote speaker, Dr. Rehma Al-Avlaki. She is a pharmacy supervisor based in UAE. Her keynote address is titled Pharmacy Leadership Certificate Management Basics. Please extend a big welcome to Dr. Rehma Al-Avlaki. Thank you, Dr.
Thank you. 15 minutes. Yes, all right. I'm gonna run on the slide.
Yeah.
So good afternoon, guys. This is Rahma. So my presentation will be a little bit away from the dental perspective. So let's go back to about the management and leadership in the pharmacy field. So this is about my disclaimer is from the ASHP, American Society of the Health System Pharmacists. So my agenda will be clearly about the leadership certificate, objective, CE requirement, professional certificate, how the online have been guided, healthcare leadership, pharmacy management, future in the hospital pharmacy, with our vision and conclusion. So what is the advocate and the win and what's the next in 2025? This was a message have been posted from the ASHP Society, from the CEO that they mentioned all the effort and the partnership of the state affiliate that about the new legislation that already didn't change in US as a country. However, that to continue long-standing all the supporting solution to reduce any drug shortages, especially that what we are facing currently, and all delivered that how to have successful effort in the pharmacy, residency funding, drug shortages, and a neutral payment in provision, which has been faced last year. And the mission is to help the people to achieve their optimal outcome and about to remain committed to the advanced 7 key priorities. So what is the key priorities in any ASHP or even in any hospital pharmacy perspective that to every time that the scope the pharmacist provided the patient care services, secure the payment, especially for the insurance pays patient, have a solution for the workflow challenges, especially that's facing the hospital pharmacy, any special rule to have a qualified pharmacy technician in line with the pharmacist, patient access to the safe and affordable medication. So let's say about the leadership certificate. So the management basic, it's actually a board certified, have been accredited by ASHP. They call it Pharmacy Leadership Certificate Management Basic. So this certificate actually it's about self-guided online learning activity have been created for a pharmacist and a pharmacy technician who are have any role in the pharmacy leadership or aspiring to be in a position. What is the curriculum have been covered? This certificate have been covering around the HR law, hiring, supervising, evaluating the pharmacy staff, scheduling, technology, any inventory management regarding the pharmaceutics for the medication and consumable, inventory control, medication safety, CQI project, which is we call it continuous quality improvement, regulatory compliance, monitoring financial performance, RCM, which is the revenue cycle management, business plan development, and anything regarding the management tool. So what is our objective from the HR? So the HR, that means you need to know what anything important that will affect your human resources, require recruitment strategies in preparing your hierarchy in the pharmacy, any necessary information to create a proper business plan for your staffing. Regarding the operation, so you need to know that how to describe any shortage in the drug market, security, your control of your inventory from all different perspectives, inpatient procedure, ambulatory clinic, any office or urgent care. Evaluate your current medication distribution system, either using the new AI, which we call it the automatic cabinet dispensing machine, or the normal, that the manual procedure. Pharmaceutical supply management, that means you know to know a principal formulary of the decision making, that every hospital have a formulary list. You need to be assured that all this medication is available 24/7, and to evaluate the role and the responsibility of your committee, which we call it PTC, Pharmacy and Therapeutic Committee, leading by a chief medical officer in your hospital. Other thing about the safety and the quality, to analyze your any error because of the medication have been inappropriate using in the hospital, to actually differentiate if any risk medication, to stop any stages of the inappropriate use of the medication, regulatory compliance, productivity, and the practice management. So how we take the requirement or to complete the requirement of the CE to achieve this certificate, which is the board certified, you need to make sure that this module have a civil learning module. Actually, it can be possible and open for the pharmacist and the pharmacist technician who have a position in the leadership or management. The rule is to make sure that you receive 20 CME hours by completing all civil modules. The participant makes sure that this activity by completing the evaluation and all the required components to assure this credit online have been done by the SHP. So that means all this claim will be viewed as statement that you credited within 60 days and need to complete this activity. Final assessment makes sure that 80% of the passing score. So what is the other catalog of the SHP professional certificate? Actually, it's educational product line to offer any high quality practical education training for the practitioner and especially for the pharmacy personnel. That makes sure that it's easy managed to be succeeded because it's 100% online. That makes sure that also that to claim the C and after each module, because that will be one of the mandatory to assure that you will receive the certificate. Then an educational product line covered the clinical topic, which is including your practice and general development topic, which is the steroid compound. So the leadership message, this is actually our role model, Sheikh Mohammed Rashid, but he said that leadership has never been more important in a healthcare than a vital factor, which is highly ranked in the healthcare organization, which will need to be capable, high-quality leader who embody the collective leadership style essential to support a high-quality patient care. That means clinicians are viewed accredited leader. Without any strong leadership, even the most innovative strategy and talented team can be faltered. The true leader does not derive a power from his position, but from his ethics, from the people who love for him, and from the knowledge, education, excellency in his field of work. So pharmacy management. So how is the pharmacy management contained? Actually, it's overseas. I can mention it as a day-to-day operation, covering all the perspective, universal, goal-oriented, continuous process, multi-dimensional, group activity, dynamic function, and intangible forces. So about the system feature, there is a two different type, or many different type actually, about the computer system using the pharmacist. It can be web-based ordering system. We have in our Sheikh Khalifa Specialty Hospital, Ras Al Khaimah, we call it Cerner. And there's an inventory system. We have as another system, we call it Oracle-based, and automatic dispensing cabinet, which is that all the hospital perspective now to go toward the AI. It's called either the smart system, which is called automatic dispensing cabinet. It's another allied to the pharmacist. So we cannot actually ignore the important role of the pharmacist and the technician. But actually, this will like the smart system always can be aid to the personnel on the floor. The future of the hospital pharmacy management system. So all the future will utilize being on the cutting the edge of the technology with the AI and the machine learning, technology that aims to streamline the pharmaceutical operation, enhance the patient safety, ensure the regulatory compliance, especially that we have most regulatory compliance here in our country. It's the MOHA, Minister of Health, and align with other authorities like DHA and DOH, which is Department of Health in Abu Dhabi. Digital healthcare sector made to grow financially. there are a greater demand than ever for the specialist technology solution, which is that through the software, it's a very important or can be significant instrument for improving the operation effectiveness, raising the customer happiness, and supporting the revenue development. Central to this revolution, therefore, all this technology is revolutionizing every aspect in the healthcare service, excellency from the inventory management till the patient education and engagement. So what does the pharmacy management contain? So it is inventory management. Inventory management is a take and manage the inventory to the level that make sure you manage the expense and run effectively. So that makes sure that any demand forecasting, which we call it that a formulary forecasting, that will start with the planning phase. Inventory planning, make sure that you're demanding based on your hospital need as matching the requirement. Then you do a proper tracking and control by having a proper top-up protocol in your hospital. Then follow up with the procurement, then inventory optimization. So by have this proper process, we can assure your inventory management will be successful in your hospital. So what is the workflow system in that? So you need to make sure that if you have any robotic system, make sure this operation workflow of the pharmacy benefit the manager, increasing the utilization of the automatic dispensing system in the pharmacy. Make sure the automation and the workflow are work aligned with each other, not separated. That will help the improving the workflow in your pharmacy. With the prescription dispensing, it will be more accurate and efficient, which is thanks to the workflow system, and it will help you to track the order from the point of the entry by the physician till it's being dispensed by the pharmacist. Also, make sure that a market overview of the hospital pharmacy management system, that will be an outline of the any system by covering all the essential aspects, combining with the quantitative and the qualitative investigation. So that's been, we'll have a macro overview of the market appraised, industry chain, streamline the scale of the point, interest of the promote area by the sort and application. So how is the expansion in the market? By have a technology advancement that makes sure that all this electronic prescribing system have replaced the traditional phase, which is the paper phase, reducing all the error and increasing the efficiency, which will help even the physician to communicate better with the prescription and reaching the pharmacy through the electronic phase. And that will help even your inventory management to be well managed to have a proper maximum and minimum scale. Regulatory compliance, which will also help your healthcare sector to have a regulated bodies that will make sure that it's compliance with all the requirements, will help you against all the agency, as I mentioned earlier, with MOHA, Minister of Health and Prevention, and other capabilities documentation. Emphasize also on the patient safety and care, that all this industry will prioritize the patient safety and care with the proper utilization of their pharmacy management system. So what is the other four key force which is shaping the future of the pharmacy? By have a focus on keeping medicine affordable and expand role of the pharmacist, raising the consumer expectation and rapid advance in the medical science. In addition to that, also the pharmacy care is arriving every day. That the medical science, which is will make sure that to produce a treatment and technology where it will not be unthinkable too long. However, to deliver a care is a change for better, and the technology will play a role in that. But the challenges is real, which is like a lot of like a miraculous treatment, won't pay for themselves, consumer and the plan sponsor alike, left wondering how they will be able to manage and accelerate the price. However, in UAE, you will not have this a lot of issue, alhamdulillah, where all there is an insurance and the other will be covered by the government. Expand the role of the pharmacist. Modern nation is 320,000 pharmacists have a long been in the front line of the healthcare. The data have been indicate a patient will interact with the pharmacist almost twice as often as they do with the physician. The tool of the pharmacy will continue to evolve with the role of the pharmacist, and the automation actually will help to expect it to be more than double by 2030. The use of this automation will also allow the pharmacist to spend more time on virtually and physically with the patient care. By expanding this role, you initiate a therapies and having a greater flexibility in deciding which drug is to dispense. And for example, it was in July 22 that the US FDA had been receiving emergency use authorization for the Blacksploid, which is it's one of the antivirals, to authorize the state licensed pharmacists to prescribe the Valproate to eligible patients. However, this is only in US, not in UAE. Raising consumer expectation from the patient perspective, all the streamline had been long existed between the medical behavioral wellness of the pharmacy first to their care, which has result in the potential gap in care. So the consumer, which is the client or our patient, have evolved in the era of the mobile devices, all the aspect in the healthcare, which is more seamlessly integrated as the consumer demand easier way to navigate and support their care. Actually, it's already applicable. Most of the like Sahha base in Abu Dhabi, they have a Cerner Salamatic, already have a mobile platform the patient can access to find their medication, find their blood tests, find all this needed. Then what is the vision of the pharmacy in Pharmacy 2030 is depend on the challenging. Some of the pharmacy team already pushing the boundaries and delivering the care to the other, which seem a little bit like a dream or a distant far because of the automation has not been actually implemented till now. However, the vision is recognized that everyone in the journey, it's aimed to support all the pharmacy to move forward to the new level of the professional practice, and it's evolution from where we are now, not a revolution. So I can say that the UAE pharmacy market highlight is that it's generated revenue from the USD 4,300 million in 2024 have been expected to reach at 8,150 million by 2023. UAE market expected to grow at the 11.2% from 25 till 2030. In the term of the segment, the prescription was the largest revenue generating product in 2024. OTC, as you know, it's a lucrative product that segment the registration, the fasting growth during the forecast period. So for the pharmacist, we can say that any expert that to take a leadership prescribing in all care setting who's optimized the therapeutic outcome to the individual patient. That means any shift should be away from the checking other professional work toward the pharmacist by having a clinical prescribing role to manage the care of the individual patient. For the pharmacy technician, the management is the main key role of their process, that they will have a focus on the safe and efficient supply of the medication, inpatient facing role, and support actually availability of those medication to our patient. In the conclusion, I want to say that there's a problem in the leadership whether the opportunity to take the initiative on the project and the organization. So no matter how small or large your project, it's mean that you have to be a volunteer and the building a relationship with all the leadership position, especially when you need to have this to move forward to the right direction. You will be more successful in getting others to buy in your vision, include all the designing vision to begin with. However, that to set a clear expectation, a smart target to lead that to all the expectation periodically in the situation warrant off. Remember that the importance of the reward and recognition is motivating those you to lead. That's my reference. And thank you.
Thank you. Thank you, Dr. Rana, for such a wonderful and good presentation. Any questions? So after this, we all can gather in the back for a photo session and then move ahead for lunch. And we'll be joining back for the afternoon session and I will get back to Dr. Rena, chairperson for the afternoon session. So, so the break is until 1:45. Please join back for the afternoon session at 1:45. Please gather back for the photo. Group photo.
Yeah. Okay, yes, now. Yeah. Yeah. And a delegate certificate for attendance will be provided. Yeah, like sure we have restaurant and we can join park here at 143. Good. My grades have been. Delegates. Okay. Yeah. Yeah. After I saw this, it was my first case study is what was in the SDF. بس يعني الآن حرام was a failure لأنها ما كانوا بدهم continue طلع compliance بالوقت الكبير. This is the ninth year. And I have one comment, please. The timing for the lecture is very, very, يعني there is no way we can do a presentation in 20 minutes. It was very difficult. يعني صراحة يعني I would say 50 minutes. Yeah, 30 minutes ideal يعني. With everyone is for Yeah. Yes, yeah, I mean, for the doctor to see. Yeah, I mean, for us, أنا because it will make us it will make the presenter more yeah, Victoria. Okay, no, wait, I have to say this myself for that. Yeah. But I can rush it out. And I felt myself أكل الكلمات يعني words and I still there are many things I didn't say, but at least said the most important parts. Yeah, I know. Yeah. I saw that. That was but yeah, at least we did understand the future sharing. Yeah. Yes. We think this is better what yeah. Yes. I mean, I have not many yeah. Absolutely. They didn't even keep on my phone as well. Another one. Yeah, صحيح.
I want this. I want that.
On the screen.
Me, but the floor, please, okay? You take it first. Let me take her. This is yours.
But fine, for me it's okay.
It's okay. Yeah. So, like, can I open?
You can also open it with the heads to
Okay. Okay, no problem.
For me, yes, because when the camera had been taken, it was my scale went down.
Hey, أنا كنت جاي أقول لك حط شيء.
What you want on the stage or here? It's my phone, yeah.
Teen. I think it's very light. I'm also having this one. Heavy.
It is, I think, 16.
60.
It's still was
Lighter.
the same one. Ah, no, this is the one is great. Great, and some days from the stage.
Yeah, sure.
KG. My double chin.
I think in photo it came.
Double chin?
Please.
There's a picture everywhere. No, it's okay. It's okay. Yeah, it's excellent. والله هالشيلة. Yeah.
The shift with the shell, it has to be.
ايوه والله. Thank you.
By the way, how did we get these pictures? Like, the induction with values, actually, the pictures we put it on LinkedIn and editing by tomorrow. Because they'll be editing the pictures. Yeah. Okay,
I mean, I want my presentation picture, of course, and the group pictures.
Yeah. I want the one you just took with your phone also. Airdrop it, please. Good quality. Everything.
Yeah.
Yeah, see, I'm very. Yeah, it's very good.
Yeah, it's delicate. It's written. She forgot her ID card, so I can't.
Okay, put your hands.
Yeah.
Yes. Okay, خلاص. Now read. When? Just see, we have filters to cover the face, everything, but the shade, and we don't. Still, we did not reach that. Thank you. Thank you very much. بس بصور ويا I will can you keep them just open my slides and then I will what do you want me to do?
Yeah. Okay, I think I just. Oh,
People let you know what their problems.
yes, no, it's not really efficient.
That's
Amazing.
let's get on righteous minds.
Yeah.
We try to do some of the international concept. The issue and we try to make it global.
Either do dentistry or talk about AI, but we have with that. Whichever, you can tell me what you want me to.
What we want to do is have a
Yeah, oh, I love.
so get that controversial,
Yeah.
get some very influential, maybe get some journalists. Like to come and do that. Not really more political science. The journalists, I mean, I'm sure they're really personalities. Need to come and do that, they volunteer to out. So how do we get smart? And so I have feeling like the journalists, some of them will try to go for 10,000 million. Once I make sense, so good. One day that you sit with your eyes, maybe that's or they can't go, okay, then you want you completely over something. So that, you know, you really need to think different things that we big. We start with quality quality. We want to have a backdrop as obvious, you know, that the internationalized and pretty people really get sweet. $200,000. Yes, just lots of objects here. Yeah, it's sometimes the next time you really don't have time to sit down, right? We have the conversation. Whenever you guys just let me know in advance. When you catch up on a coffee and give you an introduction. Yeah. So and I'll make it to make sure so one of the astronomics are listening close by. Arabian Ratchet. Correct. Arabian Ratchet. Correct. So due to come late. We'll let you go. Okay. Thanks. I will get back to you. Thank you.
Yeah, that's it. Yeah, we did another bus. Yeah, this one. Yeah, in not clinic, I had something. And it's like, the way he speaks and so. I meant to get you remember? Yeah, and you mentioned no, so that's funny because I'm hard. No, I just don't mean like that. No, like that's when it is. That's very That's sweet. Anyway, I can't keep any yeah. Look that. It's do you not hesitate? Let's go. Right. Start. Yes. What's the shop with this okay? But yeah, we will get to that as well. I think I'm expecting it. Oh, hello. Yeah. Yeah. Yeah, yeah. No, that's it.
Yeah.
Good afternoon. Can we start our session? All right. Good afternoon, everyone. Welcome back to the second half of our program. Now we're going to begin with the afternoon session with another series of insightful talk and poster presentation. So our first speaker this afternoon will be Mr. Moritz, CEO of NSLA Click and work in Germany. His talk entitled "For the Fair Recruiting as a Competitive Advantage in Building a Strong, Reliable Nursing Team." Please join me in welcoming Mr. Moritz. Thank him after this. Is this one? Yeah. Thank you. Mr. Moritz, please. You want the mic?
Thank you.
Yeah. Is this? Yeah.
Yes, warm welcome everybody. And yeah, my name is Moritz, and I'm from Germany actually. I think here in the it says I'm from Azerbaijan, but that's not true. I'm from Germany. Yes. Yeah, so we at NSL we believe in talent, and we believe that talent is not found by chance, but it is built through fairness, respect, and through preparation. So I myself am into healthcare for the last 15 years, and I've been working in digital health, working with mobile applications, and working in processes around tumor documentation and oncology. And now, since the last 2 years, we are recruiting for the German-speaking market. And today I would like to share our experiences, and the topic is fair recruiting as a competitive advantage. So what means fair recruiting? Yeah? Fair recruiting is not a charity, it is a strategy. Because you need reliable teams as a backbone of the patient care and of the healthcare system. And we conceptualized the program. It's a 2 years program. It's 1 year in the foreign country, where we teach not just about the skills, but also about emotional intelligence. And basically, it increases the trust of the candidates in their future in the foreign country. And that's the most important. The expectation management, we find, is a crucial factor when you go abroad and work in a foreign country. So I would like to take you on a little journey. When you think back about your own career, about your first working day, about your first week, wherever it may have been as a nurse. So I suppose everybody of us knows that you are determined, but there's uncertainty. And every one of us begins their career with this first day and with this uncertainty. So we believe that what defines success is the support and the preparation you have for the future work. And without that, the motivation can easily turn to burnout, what we learned in this morning already. So having said that, starting your career as a nurse in a foreign country, what's the reality? The reality is the overload of work, usually under recognition by your own values,
or under preparation. So that's the situation we find, not just in Germany, but also in other countries. And this is not a single problem of a single nurse, it is a systematic problem of the whole healthcare system. So the retention fails when expectation and training are missing. In the world, as we learned already, we have a huge shortage of nurses. There are 10 million nurses needed by 2030, and the aging population is accelerating that demand. So the workforce shortfall threatens the global patient safety. So our concept at NSL is, as I said, a 2-year program where we have a mentorship system, and the mentorship system already begins in the foreign country, where we teach the values, the skills, the language to reach a better trained and better prepared workforce. And then when they come to Germany or to the foreign country, a mentor is also assigned the candidate to serve for their integration and their preparation. We believe that respect and guidance are crucial to sustain and to thrive in a foreign environment. So what we want to reach and what we already reached is that we not create workers, but we create champions. What we learned also in the last 2 days, that we have to focus on the strength of the candidate. Of course, everybody has a weakness when they go to the foreign country, especially the language is usually a problem, and the focus of the language is a burden for the candidate. And we believe the motivation and the values they bring in to become a champion need to focus much more on on other skills they bring in than just on the language. So what we learned in here is that here in Dubai, but also in the other Arabic countries, you have a very well-integrated workforce. You have here 46 nations collaborating and working together in a very, very good way. But it needs, we believe, more structure. It needs more standards to also replicate that. And not that it depends too much on the just on your boss or on the single institution, but that this is happening with a more structured and formal process, and that's what we created. So we believe that one nurse can change a ward, but hundreds can change a system. And that's what we need in the world, that it doesn't depend on your ethnic background or on your belief, but that you can be a champion in your job and can serve the patient for the sake of the safety of the patient, but also for the development of the healthcare system. So we have this in our program, this process here. So first, we are consulting the institutions. So right now we're working together with 10 universities and schools across Asia and Africa. And we are consulting them basically what the requirements are to their candidates. So then we have a pool of around 4,000 or 5,000 candidates who are learning German right now. And then we have an assessment center. It's a full day of assessment where we not just check on their practical skills, but also we check on their values, on their logical thinking, about their intelligence, and all this different things. And then when they succeed in the assessment center, they can enter the skill center, where we prepare them 1 year for the work in the foreign country. We generate a report based on AI tools or instruments to equip them with the necessary knowledge how to not just sustain, but to thrive and to become a champion in the foreign country. And the feedback is very interesting, as it's the first time for most of the candidates where they really think about themselves in a foreign country, reading that report about themselves and the foreign country. Then we have a matchmaking system where we basically match the institution's values and requirements with the candidate pool. And then the mentorship program has there are two mentors. Like there's one mentor from their own group. So for the Vietnamese, we have Vietnamese mentors. For the Kenyans, we have Kenyan mentors. But then also we have a German mentor. So both are there for different values and different aspects of their integration. And then through that, with the empowerment and the integration, we can create leaders. Yeah. So the partners we work with, they of course require workers, but they also require a new leadership. And we also recruiting then the future leaders for the system. So what are the three takeaways from my side or from NSL side? So yeah, invest in nurses is the backbone of the patient safety. And invest means not just in money, but also in system. And second, build system that empower and not blame. We learned a lot about that in the last 2 days of how we can develop this kind of systems. And it all starts with good communication and with also embracing the differences in our cultures and embracing the strengths of each and every culture and every background, what everybody can bring to the table. And then, of course, create a culture where those voices can be also heard. So we can implement the strengths of each and every person and can create a stronger and more resilient healthcare system through more resilient candidates. Yeah, that was a short presentation of our approach, and I'm looking forward to the discussions, and thank you so much for your attention. And yeah, lead change and shape safer healthcare together. Thank you very much.
Thank you.
Thank
you.
Mm-hmm.
So our next speaker would be Dr. Anta, specialized in the odontology and endometric from Senegal. She will present the poster of artistic and functional rehabilitation with injected composition. Please go.
Presentation. Right? No. Okay. This one? I'm going to take it out. This one. Presentation. Okay. Peut-être. No. Okay. Is that okay? Okay. Yeah, perfect. Can I use this one?
Good morning, everyone. My name is Anta Sek. I am a doctor in dental surgery and a specialist in conservative dentistry and endodontics at the Faculty of Medicine, Pharmacy and Odontostomatology and Stomatology of University Cheikh Anta Diop of Dakar, Senegal. I'm happy to be among you and to participate in this international congress. So I come a French-speak country, but I will manage to speak in English. My presentation is entitled Aesthetics and Functional Restoration using Inject Composite, Case of Patients with Severe Fluorosis. Dental fluorosis is a condition caused by excessive fluoride intake during enamel formation. It can affect patients' quality of life and can lead to aesthetic and functional problems with enamel loss. Depending of the severity, treatment options range from blanching or resin infiltration to more invasive techniques, such as veneers of crowns. In cause of severe fluorosis, invasive and costly treatment may be considered with the advent of highly fine flowable composite. The NGC composite technique is becoming a treatment alternative. The objective in this study of this work was to restore aesthetics and functional in the patients with severe dental fluorosis associated with tooth wear. This is a 37-year-old man who came for consultation for aesthetic reason. He presents with stage 5 fluorosis according to the DIN classification. A series of photographs was taken, followed by a digital impression. Loss of superficial enamel was not, and more than half of the surface, smooth and occlusal. The patient is in a state of bemaxillary parallelism. After taking an impression, a tray was made followed by microabrasion and outpatient dental whitening over 8 days with 10% carbamate peroxide. The result of the whitening project is seen in these pictures. The prosthetists create a digital workshop and print the models. A transparent silicone cage was made from the waxed flow by the implementation of the inject composite technique after isolation of the deep etching and placement of the adhesive. After composite injection, the patient regains the aesthetic and functional of the stage. Here we have the patient's smile before and after treatment. The combination of microabrasion and bleaching is consistent with study by Punch in 2012 and wrote in collaboration suggesting it has a relevant pre-treatment for direct or indirect aesthetics restoration in case of severe fluorosis. The flowable composite technique restores the aesthetic appearance of teeth, persevere to structure, and improves width and quality of life. The implicit composition technique is a simple and effective, minimally invasive treatment after for fluorotic and worn teeth. The approach of substantial aesthetic benefits while significantly improves patients' quality of life. Thank you for your attention.
Any special question?
À 5 minutes. Moi, je sais pas.
Not a lot of questions.
Would you please tell us what is the brand, composite, and the silicone? The brand of the composite you used and the silicone. Brand of the composite filling you used and the silicone, the clear silicone.
Yes, silicone. The composite.
The brand still.
Okay, GC, composite flow, ready? GC.
And the silicone.
Silicone.
The clear silicone.
Clear silicone.
Yeah, what's the mark also?
But the logo, I.
Thank you very much.
Excuse me, my French is not good. My English.
No worries. My apologies, I should not vote for that one. I saw a curious question from the sir. Can I give the certificate first for the two first presented, then we can continue with the other. So is Mr. Martin still here? Okay. Dr. Anta, for a picture, please. Okay. Just receive your certificate. Thank you very much.
Yes.
Thank you. Thank you very much. Would you want to? Yes.
Yes.
Thank you very much. So we'll go for our next presenter, Dr. Numa. That her also will be about evaluation of the endodontic treatment failures carried out by the student in the conservative ambulatory department college.
Yes, it's my. But I'm a French.
Yeah, you can do it the way how we do it.
Presentation, yeah.
Yeah.
Oh no.
Let me do it like this first. Okay.
Mode présentateur.
Yeah. A minute.
Présentateur.
So we can do it there.
Mode.
Is it?
Maybe.
Yeah.
Vas-y.
Yeah, correct.
Okay, great. Thank you so much. Good afternoon, everybody. My name is Dr. Joumandiaye. I'm from Dakar, Senegal, and I am specialized on dentistry, odontology conservatrice in dentistry and endodontics. And I'm going to share with you our work titled Evaluation of Failed Endodontic Treatment performed for students in the conservative dentistry endodontics in our department. And this presentation will be structured as following: an introduction in which will present the context of this study and the challenges of this clinical evaluation. The protocol used to conduct this study. The result will be present, the raw data, and the main observation before conclusion. Discussion will comment on our results and compare them with those of the literature. Endodontics practice is based on the WINE report, diagnostic, preparation,
and root canal filling. It is based on essential biological and mechanical objective design to guarantee the healing and long-term survival of this tooth. Practical teaching in endodontics has a dual mission to provide excellent training for students while guarantee the quality of care provided to patients. As a result, the treatment carried out by students are technical variable. It is therefore essential to evaluate their results on a regular basis. In this context, that the present study was conducted aimed to evaluate the failures of endodontic treatment performed by students at the Clinical of Conservative Endodontology Endodontics Department of the Odontostomatology Institute of the Sheikh Anta Diop University of Dhaka during 2020 and 2001 academic year. This was a retrospective study based on the clinical records of patients treated by Master 1 and Master 2 odontology students over 1 year period. A total of 38 teeth had undergone complete endodontic treatment or retreatment up to the final coronal restoration were analyzed. Once the patient had been selected, a clinical assessment was carried out, focusing on the presence of spontaneous pain loss, of attachment pain, on apical palpation and percussion text, dental mobility, the existence of the fistulas and the sinusite adenopathy, fever coronal or root fracture and functional impotence, as well the integrity of the restoration, the coronary restoration. The comparative analysis of post-operative and 1 year follow-up radiographics were carried out to assess the quality of the endodontics treatment. This evaluation focused on filling lungs under or over station greater than 2 millimeter, density and homogeneity, presence of any missing areas or vacuum in the filling. The radiographic evaluation compared post-operative and follow-up radiographic taken 1 year. The periapical condition as also assessed using CBCT-PER. This study involved 32 patients and 38 treated, and the distribution of the T treated period showed a predominance of mandibular teeth, 52.6% compared to maxillary teeth, 47.4%. Of the 38 teeth treated, the overall results show a failure rate of 37.2%. Clinical evaluation revealed spontaneous pain in 5.3% of cases, and a coronal defector constriction in 50% of cases. In terms of the radiographic assessment, under overfilling accounted for 18.4% and 10.5% of cases respectively. Underfilling canals account of 26.3% and 10.5% of cases. The CBCT PIE revealed index score 2 and score 3 when assessment of the periapical condition. The results, this result prompted a number of comments. The main limitation of this study was the small sample size. It was difficult to record patients who had undergone endodontic treatment and the loss of the post-operative radiographic in many patient files may be impossible to compare this radiographic with the control radiographic. The distribution of the treated T according to localization shows a predominance of mandibularity with maxillarity. The small difference show that the endodontics treatment are carried out on maxillary and mandibularity without any preference. The distribution of teeth according to the type shows a predominance of second molar, which followed by the second premolar and central incisor, which each count for 18.4 of case. The results are corroborated by those of Lopez and colleagues. The results also are corroborated by Lopez in 2023. Also, endodontic treatment fail can be diagnosed clinically in our study, spontaneous pain, and defective leakage, coronal leakage, as made by Ray and Trop in 1995. Radiographically of the underfillings were not which it probably relate to lack of experience of failure, the lack of it's not working. No, it's stopping. Please. It's not showing here. Hold on, it's going on. I couldn't close it. Let me close this. So what do I take in? Okay. Thank you so much. Sorry. And the radiographic, and this study shows that underfilling and overfilling were not an issue, which is probably related to lack of experience and failure to the following instrumentation sequences. Based on the complexities of the root canal system, all canals were obturated. And while one of more underfilling canal indicated a lack of knowledge, endodontic anatomy, or poor radiography interpretation. Although all these results compare with those of Meniros and Cole in 2020. These higher failure rates found in our study reflect the difficulty account by students in putting their endodontic skills into practice. It is the need to revise the curricula, but also to strengthen the teaching of endodontics with an emphasis of the clinical phase on clinical follow-up. In conclusion, evaluation of endodontic treatment carried out by students reveal a high failure rates. They may reflect difficulties in mastering endodontic techniques, particularly in terms of respecting root canal anatomy and radiographic interpretation. Given this situation, we need to carry out a thorough review of our teaching approach. Greater investment in clinical training, including the use of modern simulation technology and more personalized and proactive clinical supervision would improve the success of our treatment. Thank you for your attention. And I apologize with my pronunciation.
Thank you, Dr. Dioma. Any question? Thank you. Thank you very our next speaker will be Mr. Tawfiq, Chief Nursing Officer and Director of Allied Health from Dubai. His talk will be the strategic role of nursing in the hospital and finance and the new script model. Please join me to welcome Mr. Tawfiq.
تمام كده؟ اوكي يوم الميكروفون
شغالة.
ما أظني والله لأن ما حد استخدمها نشوفها. أيوة شغال شحاب الصوت.
I'm Tawfiq Jizani. I'm Chief of Nursing Officer and Director of Allied Health in Apex Health Company. Apex Health Company is a Qatari company which operating in many countries, as Iraq, as Libya, as Algeria, going for Egypt, soon. This is operating for other domains, but Apex is one of the it's operating under a big company called Stadmar. Thank you. So my topic today, I'm going to talk about strategy role of nursing in the hospital, in the finance and business performance. How to move? Scroll. Which one?
This
one. Yes. Nursing is a strategy business driver, not only clinical roles. Direct influence on revenue, cost control, and hospital reputation, aligned with strategic goal and finance sustainability. So the nurses and also as well the allied health, they are doing great job and they are influencing direct the revenue and the consumption of the company. So they can really influence and impact deeply the revenue and the finance domain in the company. So to improve the flow, the nurses are the main persons or main staff who are improving the flow services in volume and capacity. Shorter length of stay, the nurse can contribute to decrease the length of stay and make it shorter as much as you can, and that's benefits of the cost and reduce the cost for any company. A lower admission rate to avoid financial penalties,
That means we are, as nurse, we can reduce the admission rate. What means that? That means the nurses can do outpatient department services and can do daycare services, and the daycare service avoid to admit patients and avoid to spend a lot of money, especially in public sectors. Faster procedure turn increase, revenue potential, all these results of the nurses contribution. So cost control by nursing. What nurse can control and can influence? Okay, the consumable and the resources of the companies or the hospitals or organizational or medical centers is depend to efficiency and skills of nursing. More the nurses are skilled, more they save money. More the skills are not skills, more they will consume, more they will depend, more they will misuse the equipment, consumable instead of using one syringe one time, maybe they will misuse it and repeat again and they repeat the procedure. IV cannulation, for example, if skilled nurse, she can insert the IV line in one shot. If not, she will repeat, and that's consumable. This prevention of post-hospital acquired infection also, the nurse practice contribute to reduce the infection acquired in the hospitals. Once the rate of infection will be lower, that means patient will be safe, will consume less, and patient will go home early. And inventory and the sub and the many other system, the nurse are the one who is actually and the main persons who are making the orders to the sub, and they can contribute to reduce the cost as much as you can by controlling their sub-stores, not only sub-stores and chain of who knows, okay, inventory management. It's that the role of nurses that they will contribute in that domain. So revenue generation by the nursing lead clinic and well program. If the nurses lead the clinic properly and manage her clinic with her doctor contribution, she will reduce the cost. Okay, and can accommodate more patients if you will control the timing and everything related to her clinic. So for the vaccination and the service of all dialysis, all nurses are contribute that. Patient satisfaction, once patient satisfied, that means patient come back to your unit and it will give you more income and revenue. Nursing business in KPI. Bed capacity rate, discharge efficiency, bed occupancy rate, revenue per bed, all these can be KPI for nursing. But unfortunately, most of these KPI has been used by other services, other departments like operation team, like medical team, but the nurses are the key persons in this KPI. So the nurses are there, and turnover cost, retention through leadership, all these contribute. So business collaboration, work with finance for budgeting and cost monitoring. What means working with finance? Once we are preparing next budget, the nurses are there and they are mostly doing the budgets. Other manpower or consumable or equipment or these things are the nurses who are controlling this. If I say nurse, I mean also allied health are there also, and collaborate with procurement for cost-effective purchasing by selecting the good items, selecting the best items, and the durable items. Partner with marketing for patient education campaign. The nurse also contribute to all campaigns like vaccine, like diabetes, like breastfeeding. There is a lot of things that, and also they can collaborate in the community for these activities. Coordinate with quality for excellence and compliance. So for regarding policy, procedure, these things are there. Why investor and owner should invest in nursing? Revenue grow, skilled workforce. This is why the people has to spend and invest in nursing. More you invest in nursing, more you save money. More you neglect the nursing, more you will spend a lot of money, and you cannot notice it by eyes, but it's there. And there is a lot of consumption because of this. Nurse or allied health, if they are not satisfied, they can do a lot other to improve you and take the company very up, or the company will go down at the same time by the same team. Okay, how to reduce this? Okay, what the owner should do. The owner should invest in nursing education and nursing retention, recruitment process, make clear strategic plan for nursing, how to deal with nursing, because to recruit nurse in this time and this world now, right now, it's very cost. Okay, other you will spend it, you are recruiting lower level nursing or skills, that means you are going to lose a lot the other side, or you recruit the high and one nurse skill can do work for 4 or 5 nurses, and you'll gain the one person. Thank you. So, improving health outcome, enhancing health system resilience, job creation in healthcare sectors, support nation accreditation compliance. And accreditation, all of us, we know that most of the accreditation, including GCI, CBARI in Saudi, and many others, Canadian standards, all these 90% or 80% are the nurses who are doing the preparation and everything related to accreditation. So business in nursing education, integrate finance and business into curriculum. That means we have to go the curriculum from the beginning, and when they are student, and we have to do this and emphasize in continuity of their education. We can encourage entrepreneurship, prepare leaders as leader for executive roles, which is not well done till now. So, nursing recruitment and business priority, address global nurse shortage, retention. If you retain your nurse, you will save 40 to 60K as per nurse. If you retain your nurse, you will save that much money. If you lose it, that means you will pay mostly double. Competitive salary and growth pathway. We should not be thinking too much to give good salary to the nursing, as you are giving lower, as you are losing from other side, and gaining one salary or two salary or 2,000 or 3,000 dirham for one salary, it will cost for the other maybe 10 times more. Supporting and rewarding work culture. Work culture, as all of us we know that it's not really in the favor of nursing, because once you go there, you will find the blaming culture, all the things remain here, and any problems go back to nursing, because they are the one who facing the patient, they are the one who patient don't know what is ongoing outside, but he can see only the nurse, she's in front of him, and he thinking that she is the origin of the problem. Okay, we can not blame the patient, but we can blame the managers who are creating the hospitals or something. They should know that, and they should not promote the blaming culture. Nursing retention, and this is, I talked about it already, that's to retain the nurse, that means you save money. More you return, more you save. Okay, investor fund, advanced training and recruitment. As I said, MOH include business in national nursing curriculum, hospital owner make nursing grow, a core business strategy. That should be in their strategy from the beginning. They should not make correction in between or make root cause to look where is the problem, why the problem is in the recruitment process and the strategy plan. Thank you very much. This is the references. Thank you. Any question?
Thank you.
We already said what is the question. You already did it.
Huh?
So no question. You already did it.
Yes.
Thank you. So we'll go for our last speaker, Dr. Inas. She will have a title of dental fluorosis, the dilemma of artistic and functional prosthetic management. Welcome, Dr. Inas.
Presentation.
Hello, everybody. I'm Dr. Ines Azouzi, Associate Professor in Fixed Prosthodontics in the Military Hospital of Instruction of Tunis and the Faculty of Dental Medicine of Monastir. I'm very happy to be among you and to end the 4th International Dental Advanced Dentistry and Oral Health UCG conferences. And I will deal with dental fluorosis, dilemma of aesthetic and functional prosthetic management. Before starting, I would like to apologize for my Tunisian English. So I will be grateful if you be patient and try to understand me. I know that I will make some pronunciation mistakes, but I'll do my best. Donc, first of all, dental fluorosis is a developmental enamel defect resulting from chronic excessive fluoride exposure during dental formation. The risk increases with both the timing and the extent of fluoride exposure. And there are several sources of fluoridated water, drinking water, salt, milk, toothpaste, usually and routinely used in our days. The hazard quotient is the ratio between chronic daily intake by the reference dose, and when it exceeds the value of 0.5 milligram per liter, as recommended by the World Health Organization, it may lead to dental fluorosis. In our country, in Tunisia, several regions like characterized by ground source water rich in fluorosis, in fluoride. And we found that the concentration exceeds the World Health Organization threshold of 1.5 milligram per liter. That means that there is a high risk of these dental anomalies. First of all, we have to start by a thorough diagnosis. First, mild forms are characterized by faint lines, faint white lines, which are similar to the enamel striating during its development. And as the severity increases, we may see brown spots. It may merge, and we can see even pitting and grooves on the buccal surfaces for more severe cases. And in the advances case, we can dental we may exhibit brown or even black stains associated with enamel loss. So we must make a thorough differential diagnosis with amelogenesis imperfecta, dentinogenesis imperfecta, with MIH, mineral incisor hypoplasia, and white spot lesions through clinical history, particularly according the timing and the extent of fluoride exposure. Also combined with visual examination under thorough under correct lighting, and actually advanced diagnostic tools such as spectrophotometry may aid to differentiate these fluorosis as it gives a more lighter effect than white spots. Now, several classifications were proposed. Generally, we choose the Tierstrop and Furchkov classification as is the most detailed and significant. It's chosen over Dean's classification because the last is generally used with epidemiological studies. It gives a simplified classification, but have an overall idea of the aesthetic outcome without taking into account the structural modification in the dental tissues. So the TFI is more precise and more detailed. It's a 0 up to 9 score, enabling the dentist to make a right diagnostic. And beyond its clinical manifestations, these dental disease may have psychological and social impacts. In fact, the affected patients generally express diminished self-esteem, social withdrawal, and also in some cases embarrassment due to their dental appearance. That's why we have to emphasize on the timely and convenient or appropriate management. That's why we generally opt for the therapeutic gradient, which offers a range of solutions, of interventions tailored to the severity of the fluorosis, as well as the special aesthetic and functional patient demands. It allows the patient to start, the practitioner, to start with the least invasive, like previously said in the last poster, with bleaching or micro abrasion. For advanced cases, we have to manage this fluorosis with prosthetic solutions. They may be veneers or full coverage crowns, and the decision to start this prosthetic management depends on clinical and patient-centered factors, which are pain, discomfort, what else? Pain, discomfort, and so functional impairment, aesthetic concerns, or when the minimally invasive solutions fail to deliver aesthetic outcome. So for the first clinical case, it was a 25-year-old patient who is consulting with the chief complaint of anesthetic white lines on her buccal surfaces in the anterior teeth. She reported that she suffered from this discoloration since her childhood, with similar dental aspects in her family members. She expressed her desire for an aesthetic improvement. Also, on investigation, we found that she is from Qirwen, which is a region in Tunisia known for its high concentration of fluoride in water sources. That's why, okay, we start, that's why we decided, given the high aesthetic demands of the patient and the substance loss, to opt for ceramic veneers to improve the aesthetic outcomes. We started first of all by a DSD to preview the final result, impression taken, veneers conception, and here we will deal with double etching with orthophosphoric acid, and we see an improvement in the final outcome. For the second case, the patient was 45-year-old, and she consulted for anesthetic yellow to brown spots on the buccal faces of all maxillary and mandibular teeth. She reported that she is from Gafsa. She has a familiar pattern. Given the we made the panoramic radiograph, which confirmed the elements pointed out by the clinical exam, and as we note here, which is confirmed by the periapical radiograph, we have an advanced root resorption of the lateral incisor. That's why the following treatment was decided. First of all, we will start by orthodontic referral to address the misalignment of the mandibular teeth. And here, as we see, the pre-orthodontic treatment 3D simulation will project the final teeth positioning and allow to assess the occlusal impacts. After that, the extraction and immediate implant placement on the side of the left lateral incisor. And given given the demand for the patient of a timely rehabilitation, fixed rehabilitation, and after the agreement of her orthodontic, we decided to start the prosthetic rehabilitation of the maxillary arch while simultaneously with the orthodontic mandibular Invisalign orthodontic treatment by Invisalign. After teeth preparation, we can notice an improvement in the baseline color. It became less more uniform, and in this step we have to use a special tooth guide which will record the optical properties of the prepared teeth as long as the 3D master tooth guide. And this will facilitate the communication with the technician lab. For a better natural aspect, then we have made the impression, the global impression, and conception and veneers fabrications. As we see here, there is an improvement in the aesthetic result. Attention was paid to create a natural aspect with specific surface characterization as well as incisal translucency. And when dealing with these two cases, several questions may come to mind. Can we bond on fluorotic enamel safely? And are there some particular precautions? Several studies have studied the effect of bond strength on fluorosed teeth. They confirmed that there are no pre-treatment precautions. However, the bond stress to fluorosed teeth is lower than sound enamel, but can still be carried out reliably if we consider some parameters, some key recommendations, and we will try to deal with some tips and tricks to improve the adhesion. The first one is the choice of the adhesive system for bonding this type of teeth. So the first one only.
Sorry, that's last one.
Okay. So we have to choose. We have to choose etch and rinse pursued by three-step adhesive systems. We have to increase the etching duration in order because of the acid resistance of the fluorosed teeth, and to increase the concentration of the orthophosphoric acid. The best concentration is 40%. Some authors recommend the deproteinization, which is the application of of some agents such as the vitamin C and the hypochlorite sodium, which will demineralize which will dissolve the organic surface and facilitate the attack of the etching of the mineralized surface. Let's move on. The vitamin C will have the same effect as well. The last case highlight the importance of the challenges of treating a fluorosed a patient with dental fluorosis of TFI of 8. In this case, we must opt for full coverage crowns. to mask the underlying discoloration, and in order to achieve harmonious gingival arch, as well as to address the left to waist ratio, we opt for crown lengthening. And here is the final result. So here is the patient who sent us how he was taking pictures without smiling. He avoided to smile, and after fixed prosthodontics, it was really a marvelous change. And finally, I have to highlight the importance of the clinical examination, which must be completed with an accurate diagnosis. We have to opt for preserve as much as possible the sound tooth structure while meeting the patient's expectations, and we have the possibility to combine two treatment modalities. I would like to thank you for your attention, and I can't end my presentation without inviting you to join us in Tunisia. You won't only enjoy Dr. Kakwarka and Ruzi Jerbi, but there are plenty of things you may enjoy in Tunisia. Thank you very much, and sorry for my pronunciation.
Any questions? Okay, thank you. So we came to the conclusion that our closing session for today, and the conference will be resumed tomorrow in a virtual format. Thank you very much for attending today.
أشوف لك إياها أنت موجود هني. حط لك إياها برزنتيشن فورم عشان تعمل الصورة. أي شيء.
أيوة.
أي.
On this side. For here.
The black. Well, they need to be on up in the traffic. That's what I'm saying. Because no. You can hold this one. Thank you. Miss Nadia? Yes.
Thank you. Thank you. Thank you very much. You don't want. Any from the delegate here? We don't have things, right? I just want to share this going on. I just touch my face with big smile. Any delegates? We can hand over the certificate, please. Oh, yeah, there's. Thank you so much. Yeah, thank you. Welcome, yeah. Thank you. Bye bye. Bye. Yeah, good morning. In the middle? Thank you. Okay. So pleasant to meet you. Which one? I still have a few days to go. Yes. I think it's not that. You know, having something that was making really paying for that. Yeah. After the night quiet, I'm very tired. Yeah, you're okay. I was in the so he did so it's not I'm the next do. I don't know. Wait, I was like, you know, no, because it's yes, yeah. I went to change the I compared to 20. Okay, for very good investment.